Okay, good morning, good morning. Get a mic check here. Those of you that are joining us virtually, if you can hear me, please let me know in the comments. No, I do not want the software update. Okay, how is everybody this Monday? You guys have a good weekend? Good. Oh, thank you. Yeah, I had a good day. I had was able to spend time with all of my kids and my granddaughter, and it was a good day. And my mom. It was a good day. Good day. So before we get started, does anybody have any questions for me? Anything that you want to ask about the class, about testing, about anything? Everybody good? All right. So over the weekend, you had two chapters, chapters 5 and 6. 5 was on dementia. 6 is on skills. So when I call your name, if you can tell me either your score or how many you missed. Michaela, Joan, Sheila, on 5? What about 6? Thank you. Tier, I know Tier's, Sebastian, Egypt. Okay. And 6? Very good. Damon? That's fine. Charlene?
She's coming in late.
Okay. Brianna, thank you. Simon? Mackenzie? Thank you. Yanizalith? Nathaniel? Thank you. Nathaniel, do you happen to have 1 through 4 for me? Okay. Somehow I've missed those. Sorry. Okay. Thank you. Jocelyn? Thank you. Vernage?
80 for chapter 5 and 75 on chapter 6.
Very good. All right. Do you have any questions about what you missed? Anybody have any questions about what they missed? No? All right. We're going to, did you guys register for the test? Anybody register for the test? Not yet?
You have to have your background, correct? And I can't do it over like the weekend or whatever.
Right. So the background check would be step 1. Good morning. If you can't, if you think you have a background check that will work, you can go ahead and apply. But remember, if they don't find it in the clearinghouse, it's going to delay the whole process. Just keep that in mind. But you should be registering. So if you register for the test now, you should be testing about 2 weeks after graduation. So kind of keep that mind, that time frame in mind. Could be 1 week, could be 3 weeks, but some, on average, it's going to be about 2 weeks. Now, if some of you have an obligation, because right now we're in the middle of May, so that means that you're going to be testing somewhere in the first to middle part of June. Okay. This is kind of the busy season for testing because all of the high schools and vocational centers and community colleges are all graduating now too. So this is kind of a busy season, so it might take just a little bit longer. So around mid-June is probably when I expect you guys to be testing. But let's say you've got a vacation planned in mid.
I'm not quite sure how to help you with that.
Stop. Let's say you have a vacation planned and you can't, it's going to kind of interfere. Well, then put your application off a week. Wait a week to test. But let's say that you do the whole registration process and they assign you test dates. They don't ask you what date do you want. They assign you a test date. So let's say you've got that vacation planned in mid-June. You apply for the test. You get the test date in your email that says you're testing right smack in the middle of your vacation. What do? All you have to do is call them up and tell them that date does not work for me. I'd like to schedule a date while we're on the phone, and then they will find a mutually acceptable date. But here's the thing. They're going to ask you why. You don't want to answer that question. Don't answer it. Just say that date just doesn't work for me. That's all you have to say. You do not have to give them a reason. Okay, just that date does not work for me. Because if you're rescheduling for something that they consider trivial, they'll charge you a fee. So just that date doesn't work for me. Okay, transportation, childcare, it conflicts with something else. Just that date does not work for me. That's all you have to stick to. Make sense? Good? Okay. All right. Remember, we have the game show next Tuesday. So it'll be your last week of class, but you might want to put this on your calendar because I'm doing a game show on your last week of class. This is going to be very relevant to you because it's going to give you 15 test-like questions, and you'll get to see how the questions are going to be formed, the type of answer choices you will have, and I go over the right answers and why they're the right answers. So this becomes a really good practice test opportunity for you. Okay? All right, so how do we know what to do with each patient? We follow the care plan. We follow the care plan, the whole care plan, and nothing but the care plan. That means we don't add to it, take away from it, or change it in any way. While we're following that care plan, we should be observing for any changes or abnormalities. And who do we report those changes to? The nurse. Yep. Every skill starts with the opening. Every opening starts with a knock. Sure. So that's a graded checkpoint. Please do not forget to knock. Once you've knocked, you're going to greet the resident by name. And then you're going to introduce yourself by name and title. Hi, my name is Patty. I'm your CNA today. You want to explain what you're there to do and then get permission. And once you've done that, you'll close the curtain and wash your hands. Now you've got clean hands, we can go get our clean supplies. While we're thinking about supplies, we have to consider whether we need gloves. If we need gloves, if we're going to touch body fluids, personal skin, non-intact skin, then the first thing those gloves should touch is the patient. We're going to keep our gloves clean for the patient. Absolutely. And then we're going to take those gloves off correctly so we're not cross-contaminating. So on the topic of supplies, we have to have a clean place to put them. So a barrier is anything that separates your clean supplies from an unclean surface. But for the test, we'll use a very specific type of barrier, an underpad. So you'll go get the underpad, put it on the table, go get your supplies and put those on the chucks or underpad. Don't hold those items up next to your uniform and only touch your supplies with clean hands. So one of the people that are on my YouTube channel gave me a comment that they messed up on the exam and they weren't real sure whether they were going to pass or not, because in Florida, you get your results the same day. So when you leave the testing center, you will know whether you passed or not. Not all states do that. Most states, you leave the testing center, you have no idea if you passed or not, and those results don't come until hours or days later. So this person's on pins and needles right now, waiting to see if they're going to pass. But her biggest thing that she messed up was she carried all supplies into the room before she ever did her opening. So what kind of hands did she touch those supplies with? Yeah, so we have to be aware that these steps count for a reason. And the reason is usually patient safety. Does that make sense?
Mhm.
Okay. Privacy blanket may be needed for the test. We're going to use this anytime our patient is uncovered or undressed for whatever reason. When we put this on, we don't snap it, we don't shake it, we lay it over the sheet and pull the sheet down underneath. And then at the end of the skill, when we're all done, we're going to take that privacy blanket off after we take our gloves off. So at the very end of the skill, because you're going to need those gloves on to take all of your dirty items and put them in dirty linen and to clean your basin. You can't take your gloves off while you still have dirty stuff to put away. So we get our patient safe in the middle of the bed, covered with privacy blanket. We clean our environment. Then we take our gloves off, take the privacy blanket off, and do our closing.
But isn't the privacy blanket dirty linen also?
It will be placed in dirty linen, yes. But the big thing is, it's not about the privacy blanket. It's about the sheet.
Oh,
Because when you pull the sheet up, if you have soiled gloves on, remember, okay, so let me explain this, okay? So when do we wear gloves? If we're going to touch not just the patient, okay, body fluids, personal skin, and non-intact skin, right? So this isn't just surface level pathogen. This is body fluids, personal fluids, right? Make sense? Good? Okay. So if we have gloves on, that means that those gloves have some sort of fluid on them because that's why we wear gloves. Do you guys connect those dots? Good. Now, if we have personal fluid covered gloves, do we want to touch that sheet that's going to go right up next to her face with personal fluid covered gloves? Do you think she wants fluid on her sheets? So that's why we have to clean everything up, take our soiled gloves off, and then take the privacy blanket away. Good? Make sense? All right. Linen rules. These are all repeats of things we already know. So linens can't touch your uniform. We talked about that. You have to have clean hands to get your linens. We've talked about that. Don't snap or shake your linens. We've talked about that. Clean rolls toward me, dirty rolls away. We learned last class. And that just keeps the contaminated surface from touching the clean surface, just because of the way we roll. We're not going to let anything touch the floor. I don't care if it's clean or dirty, it doesn't go on the floor. Don't let it touch the floor. And anything we don't use, we're going to dispose of. So if we take extra washcloths in and you don't use them, put them in dirty linen. If you take an extra pillowcase by accident, it goes in dirty linen. You don't leave it in the room for later. That will be a written test question.
Miss Patty, I have a question. Okay, so one of your former students, which is one of my cousins, she in one of her facilities, they didn't have like wipes or whatever, so they had to use the washcloth to do like when he like used the bathroom on himself or whatever, and it got all the way up his back. She had to use like six rags, and I guess one of them that she didn't use, she still threw it away in the dirty linen. But is all facilities gonna be majority probably rags, not wipes anymore?
Depends on the facility.
Okay.
It does. So I can't answer that one way or another because there's a lot of factors that go into this. So first of all, we have to think about supplies. So it costs money to use wipes. You have to, they can't be reused. So it costs money to use wipes. Washcloths, you buy them, you use them, but then you wash them. Although washing costs money as well. So the facility has to do what's called a cost benefit analysis to figure out which way is best for them to go. Make sense? So I can't tell you how that facility is going to rule, whether they're going to use wipes or they're going to use washcloths. I don't know. There's benefits to both. Okay, there's benefits to both. The problem with wipes is that, first of all, there's an environmental problem because they get thrown away, right? But the problem with wipes is they generally are very, very thin. So it doesn't do a really great job cleaning, especially solid waste. So we end up using a lot of wipes. Washcloths are thicker. They do a better job of cleaning solid waste. So that's going to play into this as well. It's going to take less work for the staff to use washcloths and use wipes.
So you feel like washcloths are better? Just you.
Me, washcloths are better as long as I've got a good industrial washing machine, because I don't want that in a regular washing machine. So if we're in a home care setting, no, wipes are better. Because home care settings, they just have a washing machine, and I don't want to put solid waste in a washing machine, right? But if I'm in a facility that has an industrial washing machine, yeah, the washcloths actually make cleaning a little bit easier, a little quicker, because those washcloths are going to just get more stuff. So yeah, there's a lot of things that it's... So that's the problem, right? There's no simple answer here because we have to take into account all of these different variables, and even down to what kind of washing machine do we have?
That's why it's like depending on the facility.
It is. It's also going to depend on the patient. And if I've got a patient with C. diff, we have to use wipes. We're not going to use washcloths. If I have a patient in an assisted living facility, they have to pay for all of their own stuff. So if I've got a low income person at an assisted living facility, they may not be able to afford wipes. So we may be using washcloths. So there's going to be that component of it as well. My aunt just moved into an assisted living facility up in South Carolina. Went up and saw her right before this class started, actually. It's a beautiful facility, very nice. The staff is very friendly. It's well run. But it's costing her every single penny she has to stay there. She has no spending money. She doesn't even have $20 in her pocket. Every single dollar that she gets from Social Security goes into paying for her care. So would she be able to afford an extra thing of wipes? No. So we kind of have to think about that aspect of it as well. These supplies do cost money, especially when we're talking about disposables. Okay. Good. Does that make sense? Great question.
But with the washcloth, are we going to have the soap and water thing too?
Yes, you'll have a basin with soap and water. Yeah.
Okay. And that can have soap in it, correct? Or
I wouldn't. I would put the soap directly on the washcloth. Wring the washcloth out, put the soap on the washcloth, because you still have to rinse.
Right.
And if you put soap in that basin, now we don't have any rinse water. Then we got to go get another basin.
Right.
And that becomes an issue. Good. It is a lot. It is.
I'm trying to think, because you have one basin, and then once you get the urine or whatever on that rag,
You're just going to set it aside.
Okay.
We don't reuse it.
Set it aside, put it in dirty linen.
Well, we're going to set it on the barrier.
Okay.
Get our clean washcloth and rinse those areas, or wash more if we need to. Set that aside. Get a clean washcloth and rinse. Set that aside so we don't reuse those washcloths.
At the time.
That's really where your problem is going to be in most settings. There's just not enough linens to go around. I'm going to show you a technique that you can use on Wednesday. I'm going to show you partial bed bath.
I'm probably going to bring a little wipe, so mine, just in case I run out of linen.
Well, we're going to learn a technique to use that stretches your washcloth a lot further than you think it will.
Okay.
So stay tuned till Wednesday and I'll show you that. Okay. But yeah, it's going to make cleaning much more effective with fewer supplies. Okay. All right. Anytime we're working with a patient in bed, they must be in the middle of the bed. Whether they're on their back or on their side, doesn't matter. They have to be in the middle of the bed for safety. So if we're going to turn somebody on their side, we're not just going to walk up and turn them. We're going to scoot them toward us and turn them so that after the turn, they're in the middle of the bed. Washing rules. Everything gets washed the same way. We don't put soap in our basin. That keeps our water clean for rinsing. We're going to use a paper towel to turn that faucet on. We're going to check the water. It should feel warm, not hot, not cold, just warm. Who else has to check the water? The patient, absolutely. Whatever we wash, we rinse. Whatever we rinse, we dry. We're going to change the water if it gets cold or soapy, and it should not while you're in the test. These skills that we're doing should not take a super long time where your water gets cold. Okay. And you should never put anything soapy back in the water, so it should not get soapy. So for the test, it should not have to be changed. But in a clinical setting, things happen. You get distracted, you get talking, or an emergency comes up or whatever. Just remember, if that water is cool to your fingers or your hand, it's probably too cold for the patient to be comfortable. Don't get your surfaces wet, whether it's the bed, the table, or the floor. If we're going to put lotion on, we warm it up first and then wipe off the excess. All basins are cleaned the same way. We rinse them, we dry them, we store them. That's it. Basins are cleaned the same way. But the process allows for disinfection should it be necessary. So we dump it, we rinse it, and then we set it down. That way we can spray it if we need to. Paper towel to pick it up, paper towel to dry the inside, paper towel to dry the outside, and one more for the drawer. But for the test, just remember, they're only grading you on rinsing, drying, and storing, and they don't really care about the infection control aspect of it. I do. Remember, they're grading you on minimum skills competency. You guys all think the test is going to be hard, but I'm telling you, the bar is way down here. We're not mastering anything. We're just showing that we're not going to kill our patients once we're out there. Okay, good. And then every skill ends with the closing. Every skill ends with the closing. The closing, there's a whole lot of steps too. We want to make sure they're in a clean and safe environment. They're covered. The bed is in the low position. We have to ask about comfort, address preferences by offering them a magazine. We're going to give them their call light, open the privacy curtain. You're going to clean your hands after you've got all of that done. If charting is required, you do that after hand washing. And then you're going to wash your hands again, because our cardinal rule here is that you have to end the skill with clean hands. So if you go back to that patient for any reason at all, anything, you have to go wash your hands again. Anything. Don't take those patients' cooties away from the patient environment. Good? Make sense? All right. Pulse reading. This is just measuring how many times a heartbeat over 1 minute. We're going to count as long as the care plan tells us to. The care plan says 1 minute. How long do we count for? 1 minute. So let me read you a post that was put on Facebook this weekend. I know I took a screenshot of it here. Hold on, let me find it. Give me a minute. Okay, so this was in a CNA group. This is a post specifically from Friday at 2:40 p.m. This is when I took the screenshot. An anonymous member put this question in. When counting the pulse for the skills, which method worked best for you practicing or during your exam? Counting the full 60 seconds, or did you count 15 seconds and multiply by 4? Now, there were 3 comments. All 3 of them gave advice. One of them said 15 seconds and multiply by 4 because you don't have much time in a clinical setting. The others said 30 seconds multiplied by 2. Not a single one of them mentioned the care plan. So be careful who you're getting your advice from for the test. Do you think this person is going to pass? No, because nobody is talking about the care plan. Nobody said follow the care plan. I got on there and I said for the exam, the care plan will tell you how long to count. Follow the care plan. But if you don't understand what a care plan is, you're going to fail the test because you're going to be doing things like this, right? You're going to see, okay, I have to take a pulse. So let me figure out how long I should count. You never figure that out. That's not your job. Your job is to follow the care plan somebody else figured out. Does that make sense? So I know I talk about this care plan a lot. You guys are sick about hearing about the care plan. I get it. But I overemphasize the care plan because out there, nobody is emphasizing the care plan. If you want a fun activity on testing day, ask the other people that are there to test what the care plan says about whatever skill. Pick a skill. And watch all the blank stares. Because the people you're going to be testing with were not taught about the care plan unless they've watched my videos. All the test prep programs out there show you how to do the skills. They do not talk about the care plan. They just show you how to take a pulse. That's only giving you half the story. And that's not effective. Does that make sense? Please follow the care plan. In Florida, you have to count with 2 evaluators, and you will document your readings and then wash your hands. Dressing a resident's actually really easy. We're just putting socks, pants, and shirt on the patient because that's what the care plan told us to do. We're going to ask them what they want to wear, and we're going to get that clothing before we undress the patient. Super important to maintain privacy and dignity with this skill. We're going to lift from below, supporting all joints when we lift them. We're going to undress the strong arm first and dress the weak arm first. We don't overextend or force movement. We adjust the clothing for neatness and appearance. We're going to put the dirty items in the hamper and the call light in the stronger hand. When you take that dirty gown off the patient, does it go on the floor? No, because nothing goes on the floor, not clean or dirty. You can put it on the barrier. That's fine. You know, a small area of the barrier. Or you can put it right in the hamper. Either way is fine, but don't put it on the floor. Good morning. Don't put it on the floor. Hand and nail care. You're going to wash one hand because that's what the care plan told us to do. We're going to support the wrist and arm at all times. We'll soak the hand in water. Whatever we wash, we rinse. Whatever we rinse, we dry. We clean under the nails with an orange stick, the slanted end, not the pointed end. And we file the nails in one direction. We warm up lotion in our hands, put it on, and then wipe it off. And this cracks me up, right? And remember, these are all taken from the checklists, right? Apply lotion last. Who would put lotion on first before you wash? I mean, that's just kind of crazy, right? But if it's a checkpoint, that means that that was something that people were doing. So apply lotion last. Guys, remember I said the bar is way down here? Yeah, I mean it. It's super easy. We're going to make an occupied bed. That's a bed with somebody in it. Remember, anytime you see a bed that doesn't have somebody in it, you probably ought to consider changing the sheets because it's a whole lot quicker. But if we have to change the sheets with somebody in the bed, they're going to be in the middle of the bed on their side, and we'll change the sheet a half at a time. So we'll take that dirty bottom sheet, roll it toward the patient because clean rolls toward me, dirty rolls away. We'll take the clean sheet, put it on that side of the mattress and roll it towards you, tuck it under the dirty. And then we'll go around to the other side, remove that dirty sheet completely, attach the finish attaching the clean sheet, and then put the top sheet and pillowcase on. It's not a hard skill. It's actually kind of like a magic trick. It's a fun skill to do. Not a hard skill, but it is one of the longer skills because you have to spend so much time moving around for this one. All right, sideline position. This is all about prep work. So if we've got somebody that we have to turn on their side and they can't do it themselves, furthest arm up, closest arm crosses the chest, closest knee bent, furthest knee angled. So up, over, bent, angled. When you do that, it's very easy to just put a hand on the shoulder and the hip and roll them on their side. No stress involved. But if you don't scoot them towards you first, you'll roll them right off that bed. So remember, they've got to scoot towards you first, and then you'll position up, over, bent, angled, roll them on their side. And then we're going to use some pillows to keep them there. We'll put one pillow behind the back, one pillow between the legs, specifically between the knees and the ankles, one pillow under that top arm, and adjust the pillow under the head. The bottom arm goes under that pillow, and the call light goes in that bottom arm. Foot care. We're only going to wash one foot because the care plan told us to. So we're going to support it while we're moving. It's just like hand and nail care. Support it while we move. We're going to put it in the basin to soak, take it out to wash. In the basin to rinse, take it out to dry. Anytime it's out of the basin, you're going to make sure it's laying on a towel. No bare feet on the floor, please. We don't do anything with toenails. You don't trim them, you don't clean them, you don't file them, you don't do anything with toenails, but you do look at them. Because if they have a toenail issue, that needs to be reported to the nurse so that they can put the patient on a podiatry list. So observation is a big part of this skill. Then you're going to put their sock back on, removing wrinkles, and attach their shoe. Mouth care. How do you brush teeth? Don't overthink this. Get them sitting up, put a towel over their chest, wet the toothbrush, put a little toothpaste on it, and brush. Top, bottom, front, back, tip of the tongue. No time requirement. Just brush. Once you're done brushing, let them rinse and spit as much as they need. Dry up their mouth. Don't leave them a drippy, wet mess. And then clean up. For the test, you will throw that toothbrush away because you're a patient for this and you're not going to be there tomorrow. So throw it away. But in a clinical setting, you're not throwing the toothbrush away every day. You're just going to rinse it and put it back in the the bedside drawer, the top drawer, for use tomorrow, just like you store your toothbrush for use the next day. But for the test, throw it away. Respirations. We don't tell our patient that we're counting their breathing. In and out counts as 1. Normal is between 12 and 20. So this looks like we're taking their pulse. We're not. We're counting their breathing. You can watch their tummy go up and down because they're laying in bed. You can use an alcohol pad for this. For the test, the evaluators will count when you do. So you have to say start and stop out loud so they know when to start counting with you, when to stop counting with you, and make sure that that's a full minute. And then you'll document your readings. Range of motion. We've learned 2 range of motion so far. Range of motion is exercises done to maintain current range of motion, current movement. So we're not working on injured body parts. We're working on healthy body parts to keep them healthy. So when it comes to range of motion, we're going to follow that care plan religiously. It's going to tell us what body part, what exercises, and how many repetitions. We follow that to the letter. But when it tells us that, we have to know what those words mean. So flexion, extension means up, down. Abduction, adduction means side to side. And rotation means around. You will not have rotation on the state exam. Good? Questions? All right, we're going to learn another range of motion today. Does anybody have any questions before we move on? Okay. So I want to go over one more thing with you. This was also posted on Friday. You guys want to know why you have to take a CNA class or a CNA test, and this is all pretty basic stuff. So why do we have to go over all of this? I'm going to explain to you why. This came from Florida, the St. Cloud Police Department, actually, which is over by Disney. The St. Cloud Police Department has arrested a local home health nurse. This is a nurse, an LPN or an RN, somebody who went through nursing school, a ton of time and a ton of money. And she was only 24 years old when she was arrested this week. What was she arrested for? Aggravated abuse of the elderly or disabled. So she was recorded by a local family's home security camera, reportedly taping the victim's mouth shut and then ripping the tape off, holding a washcloth to cover the girl's mouth, and shaking the nonverbal patient's BiPAP breathing machine, which is a big mask with a tube attached to it, while the device was connected to the patient. So jiggling it so it would go up and down over her face to cause pain. The girl's mother noticed cuts and scrapes on her daughter's face, around her mouth, and on her eyelids. There was an arrest warrant. She was arrested. And she will be held accountable, and I'm okay with that. This is somebody who cannot stand up for themselves, this patient. That's why she has a caregiver in her home. And for somebody to come into your home and do this kind of stuff to you, we don't need those people in healthcare. There's no care in what she did. None. This is why you are regulated. This is why you have to sit in a classroom. This is why you have to go through a test. And this is why the Board of Nursing wants to know who you are and where you are and where you're practicing. Because of people like this. That's horrible. That should not have ever happened. If this nurse was so dissatisfied with her job, she should have left, not abused the patient. We are caring for the most vulnerable people in our community. We have to know how to do these skills correctly and ethically. Does that make sense? That one really got under my skin. This is why we talk about things like let the patient check the water temperature or watch your patient for signs of pain, which is part of what we're about to learn. This is why we have to do. It's not just enough to go in and do the task and get the paycheck. We have a higher calling. I think the test should actually be a little harder than it is. I think that the bar is pretty low.
Too low.
Yeah, too low. So don't fear the test. Fear me after the test if you do this to one of my patients. This nurse not only has to go to court to answer for what she did, but she has to go to the Board of Nursing to answer for what she did. Her license will be taken away. It will be. So all of that time, all of that money, she has to pay those student loans back regardless. She will be paying on that for a long time. but she will not be able to work as a nurse. I think both. Well, page 4 of your application, I told you you had to do that on your own. I could not help you with it. That is why page 4 of the application exists, is situations like this. It's going to ask you your mental health history. It's going to ask you how you deal with stress. And it's because, and those are new. Those questions only showed up about 4 or 5 years ago. That is a new section on the exam because we have a lot of these in Florida. Oh my gosh, just a lot. Oh, absolutely. Sure. Absolutely.
Instead of dealing with the patient with care and stuff, they treat the patients like they down south and stuff, and that's their grandchild. And they just rail at them.
Yep. Yep. And unfortunately, so this is where the whole system, I think, needs to be brought back into compliance, okay? Because you've got, unfortunately, this isn't limited to just CNAs. This is nurses. So you've got nurses who are supposed to be monitoring the CNAs. You guys are caring for the patients that I'm legally liable for. So everything you do, I'm the one that's on the chopping block for. So as a nurse, my job is to make sure you're doing your job correctly. And yet, if I do that, CNAs start to get an attitude with the nurse. Because the nurse is saying, hey, you can't talk to the patients that way. And now you've got an attitude because I'm telling you what to do. Yeah, I'm telling you what to do. The whole system needs to be revamped from the bottom up or the top down, one or the other. But it does, because right now it's too much of an us versus them mentality. So you've got CNAs that have bad attitudes and they treat these patients horribly, but then you've got nurses that aren't bringing them into line, or nurses that try to bring them into line and they get so much pushback. So the system needs an overhaul for sure. And I don't know what the answer is to that. I really don't. This is why I'm not in politics, because I don't have answers. All I can do is really push patient rights to the students I have in my class. Because historically speaking, about between a third and a half of you guys will go on for nursing. So that means if I'm giving this to you here as a foundation and you truly take it in and you adopt it, you will take that with you into nursing as well. So that's, that's why I do what I do, because I know some of you are going to go on to be nurses. You'll take care of your CNAs, but you'll also understand that sometimes you have to take care of the patients by redirecting those CNAs. Do it nice. But remember, at the end of the day, we're all on the same team for the patient. Do I think there should be a psychological exam? Yes, I do. But like you said, it's easy to snow those, especially if you're a sociopath. Sociopaths will pass every single psychological evaluation you throw at them because they know how to work people. They know what to say in the situation to work people. So it's not very helpful in those situations. All right, so let's learn our last range of motion. We've learned 2 range of motion so far. We've learned shoulder and we've learned elbow and wrist. So now we're going to move on to hip, knee, and ankle. What makes this one a little bit different than the others is this has a 2-for-1 feature to it. So we're going to do one exercise, but get 2 joints at the same time. And I'll explain to you why in just a second. So down here, you'll see the principles involved in this skill. They're all spelled out for you here. Nothing new to learn. We're going to learn our skill specific in just a minute. This is a very short skill. Somebody with your level of experience should be able to do this in 4 minutes or less. It's going to be done on another live testing student. That person will be in bed. Charting is not required. So just the skill specific is all we have to learn. Page 81 at the top has our care plan. Let's take a look at the care plan. Oops, sorry. Let me go back. These aren't the new slides. I didn't get the new slides done, guys. I apologize. The weekend kind of got away from me. So our care plan at the top, page 81, says, provide the following range of motion exercise to the resident's right hip, knee, and ankle. Right hip, knee, and ankle. Which one am I doing? Can I do the left too? What do you think happens if I go in and accidentally do the left instead of the right because I got my right and left mixed up? Something bad happens. There's a reason we're not doing the left. If the left was okay to do, the care plan would tell us to do the left. Since care plan doesn't tell us to do the left, if we do the left, something bad is going to, I don't know what the bad thing is. Depends on the patient. But something bad's going to happen. So keep that in mind. This skill is failed a lot on the CNA exam because people don't follow the care plan. I told you I've been doing this for like 17 years, right? I hate to admit this. When I first started teaching, I didn't know how the test was structured. I knew very little about the care plan, and I was a nurse. Let that sink in for a second. We learned how to write care plans in nursing school, but nobody ever explained to me what they were for. We learned how, we didn't learn why. There's a big part of our education that was missing. So when I got out and I became a nurse, I wrote care plans, but I didn't understand that nobody explained that you couldn't do anything unless it was on the care plan. Nobody said that. And there are a million nursing schools out there now that are not telling nurses that. So when I first started teaching 17 years ago, I didn't understand all that. And I would teach my students something like this. Okay, listen. So we're going to do range of motion of the hip, knee, and ankle. So when you go in and you're taking your test, do all 3 exercises so that you get extra credit. So those evaluators know that you know what you're doing. So do all the exercises. Do it, flexion, extension, do abduction, adduction, and do rotation. That's what I would tell my students. And I was shocked that they were failing because they did more. They should have gotten extra credit, right? Why were they failing? They didn't follow the care plan. So once I started realizing, okay, wait a minute, the way I'm teaching is wrong here. How do I teach right? I had to go back and relearn everything from the ground up. And that's how I created my course. So you guys are getting the benefit of 17 years of trial and error. I've got it dialed in so good now that you guys are going to get 100%. But it wasn't always like this. Now remember that most instructors haven't gone through that process. In fact, if you're the patient for this, remember it's live patient skill. If you're the patient for this, chances are whoever's doing these exercises on you are going to go above and beyond looking for extra credit. So when you're the patient, don't try to help them. Because if you resist, if you try to give them some sort of eye signal, if because you're going to know, hey, wait a minute, it's not on the care plan. If you try to direct whoever's doing these skills, you will be dismissed from the test for cheating. Does that make sense? All right. So the hip is a 2-for-1 exercise. So when your patient is laying in bed and we are going to bend that leg up, we don't want to do a straight leg raise. And I'm going to show you why in just a minute. When you bend that leg, that hip up, you want to also bend the knee. So we're getting a bend here and a bend here. It's a 2-for-1 exercise. Now, the reason for that is this. When you do a straight leg raise, you see how this leg, the knee is straight and the leg is being bent. So we're bending that hip. When you do that, there is a nerve that comes down on both sides of the backs of your legs. This nerve is the sciatic nerve. It actually comes straight off of your spinal cord. Down at your tailbone, it branches out into 2 sides, this sciatic nerve. Now, this nerve is kind of like a rubber band. It has a little bit of give to it, but not a lot. And as we get older, the rubber band gets older too and a little more brittle. So that rubber band when you're young will stretch so you can bend that leg up straight and that nerve will stretch. But as we get older, that nerve is not as stretchy anymore. And if you try to do this, it'll pull that nerve tight. Now remember, that nerve is connected to your spinal cord. So what is that doing to your spinal cord? Pulling it tight. This causes pain. And that pain is called sciatica. Anytime you get pain, you get inflammation. So now we've got inflammation in the bottom of the back, the butt area. We got inflammation, and that inflammation can actually take months to go away. So we don't do straight leg raises. When we bend the hip, we bend the knee with it. Good? Make sense? So we're going to do that 3 times. So bend the knee to the chest, back down to the bed. Knee to the chest, back down to the bed. Knee to the chest, back down to the bed. 3 times. Then we're going to move on to the ankle. We're going to bend that foot forward and backward. So we stretch forward and backward like they're stepping on a gas pedal. But we don't want that heel, as we're bending it forward and backward, to scrape against that sheet. So we want to lift that leg up just a little bit and bend the foot forward and backward. Just like you see there. And we're going to do that 3 times because our care plan told us to. So there's your care plan. Provide the following range of motion exercises to the resident's right hip, knee, and ankle, flexion, extension. So 1 exercise, just up, down to the hip and knee, up, down to the ankle. 3 times each. Put an opening in front, a closing behind. There's your whole skill. 4 minutes, that's generous. You don't need 4 minutes to do this. Super quick, super easy. Good? Questions? All right, I'm going to show you the video on this one because it's got really good close-ups, especially of that hip and knee one. So let me go ahead and show you the... No, we don't. Ooh. Thank you.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Doing great. How about you?
Wonderful. I need to do some exercises on your right hip, knee, and ankle. Is that okay?
Yes.
I'm going to close your curtain. Let me go wash my hands, and I'll be right back.
Okay.
Okay, I'm going to do all the work. All you have to do is let me know if there's any pain or discomfort as we do this, okay?
Okay.
The first exercise is going to bend your knee up to your chest and back down to the bed like you're climbing stairs.
Okay.
We'll do this 3 times.
Okay.
Please let me know if there's any pain.
All right.
I'm going to support under the knee and under the ankle, and we're going to lift and bend all the way up and all the way back down. Feel okay?
Yes.
We're going to do this again, all the way up and all the way back down. Still okay?
Yes.
1 more. all the way up and all the way back down. Next exercise we're going to do will be on your ankle. I'm going to lift your foot off the bed and we're going to bend forward and backward like you're stepping on a gas pedal.
Okay.
We'll do this 3 times.
Okay.
So I'm going to lift and we'll bend forward and backward 1, forward and backward 2. Feel okay?
Yes.
And 1 more. Okay, any pain or discomfort?
No.
Is there anything else I can get for you while I'm here?
No.
Magazine perhaps?
No, thank you.
Okay, let me get your call light for you and I'm going to open the curtain.
All right, thank you.
Here's your call light. If you should need anything at all, please let me know.
Thank you.
I'm going to go wash my hands. After washing my hands, I'll review the steps of my skill, make any corrections, and tell the evaluator my skill is done. All right.
Miss Patty, shouldn't we give the call light first, then close it first?
Doesn't matter.
Oh, okay.
Does not matter. That call light is just as dirty as that curtain. Patients in bed scratch what itches. And then they'll use the call light to tell you all about it. So call lights are not clean. Curtains are not clean. But it's okay because you're going to go wash your hands right after you touch all of those things. So, all right. Good question. Oh, I'm going to go through these. All right. So any questions on that? Any questions on that? Okay, we're going to move on to denture care. Now, we learned mouth care on our last, let me just make sure that I keep us on track here. We learned mouth care on our last class. So we know how to do mouth care. Denture care is a little bit different. Similar, but a little bit different. And because the patient has dentures, we kind of have to talk a little bit about dentures themselves because most people aren't that familiar with dentures other than what you see in the cartoons. So we're going to talk just a little bit about those. If you look on page 96, this is our overview of this particular skill. All of the principles involved there, they're all spelled out here. This is skill specific. Down here is your testing information. Somebody with your level of experience should be able to do this in 13 minutes or less. Remember, they gave us 11 minutes to brush teeth. So way more than you actually need, okay? 13 minutes or less. This is done on a live testing student. Don't panic. I'm going to go over that in a minute. And they'll be sitting in a chair. Charting is not required. Let's talk about that live testing student thing. In order to understand how this skill can be done on a live testing student, we have to read the care plan. So on page 97 at the top of the page, we have our care plan. Our care plan says a resident with dentures is sitting at an overbed table with their dentures in a denture cup. So your patient is already sitting in a chair. It's a little table like this in front of them. And the dentures are out of their mouth and in a cup. This is how the skill starts. So you're not taking dentures out of anybody's mouth. They're already out. They're in a cup. And that's important because CNAs do not take dentures out. Ever. You do not put dentures in. Ever. Unless you have been specifically trained. Now, why is that? Let's talk about the out. If I have dentures in my mouth and I want to take them out, my fingers, especially on the bottom, okay, my fingers have to go way back here to the very back part of the denture. So I put my fingers in my mouth and I have to pop that denture up off of the gums to get it out of the mouth. Now, in this configuration, right, the way that my hands are, I will never put enough pressure on my lower jaw to dislocate it because of the way my fingers are positioned. But if I were to put my fingers in your mouth, all the way to the back to pop those dentures up. These knuckles right here, these two knuckles have to press down in order for leverage to bring my fingers up. I have to have something to press down on to get the tips of my fingers up. Because of that, you risk dislocating the patient's lower jaw. This is why CNAs do not take dentures out. The patient has to be able to do that themselves. You also do not put dentures in. Patient has to be able to do that themselves. And that's because if I put dentures in my mouth, in order to get them to seat properly, I have to bite down. That's how you get dentures in place. Well, if your fingers are in their mouth and they bite down, what's going to happen to your fingers? You're going to get bit. And it's not the patient's fault. They're responding to an impulse to bite down to seat their dentures. It's not their fault your fingers are where they shouldn't be. But that doesn't mean it's going to hurt any less. So CNAs do not take dentures out. We do not put dentures in. The patient has to be able to do that themselves. If they can't, they don't use dentures. We puree their food. We chop it up really fine so that they don't have to chew. Good? Make sense? So that's why this care plan says what it does. Patient will be sitting in a chair at the side of the bed with their dentures already out and in the denture cup. Now let's go on and read the rest of this care plan. It says the resident's denture needs to be brushed with toothpaste and the resident needs mouth care. So we're going to brush the dentures and we're going to brush the mouth the dentures came out of. The denture is stored in a denture cup after cleaning, and the resident is not able to provide their own mouth or denture care. So that's our care plan. So dentures are in a cup. We're going to clean the dentures. We're going to clean the mouth the dentures came out of, and the patient can't do it themselves. It further tells us how to clean those dentures. And that's because there's a couple different ways that we can clean dentures. Before I get into how to clean the dentures, we kind of have to define what a denture is. So when we're talking about dentures, most of us, when I say the word denture, most of us think of something like this. This is a full plate. All of the teeth have been replaced. This is an upper because it has a palate, right? We go up against the roof of the mouth. This is an upper. All of the teeth have been replaced. This is called a full plate. But if the patient still has some healthy teeth, we don't like to remove healthy teeth and replace them. So if somebody has some healthy teeth, we would make something called a partial. Now, this is a partial. It has some teeth that have been replaced, and it has some cutouts for the patient's natural teeth. So this would fit around whatever's already in the patient's mouth. So a full plate replaces everything. A partial replaces some. And then we have little bitty pieces of denture. This is called a bridge. Now, most bridges now are implanted, so they're not removable. But you may still have some older people with removable bridges. These are just small pieces of denture. They usually have some loops that connect them to surrounding teeth. Good? Questions? So a couple different types of dentures. In most cases, dentures, especially the older ones, need to be stored in water. Don't leave them out of water for very long because they get very brittle and they can break. So most dentures must be stored in water. And we have to use cool water, not hot and not super cold, like ice water. Just cool water is what we're looking for. The reason we don't want to use hot water is because there's a physical principle. Heat coagulates proteins. And what that means for you, these dentures are going to be covered in proteins. There's proteins in the food we eat. There's proteins in our saliva, and there's protein in the denture paste that we use to hold these dentures in place. So proteins. Heat makes proteins stickier and harder to remove. So we don't want hot water when we're working with dentures. Cold water is best, or cool water. Good. So a couple different types of dentures. They should be in cool water when they're stored, and we're going to use cool water when we clean them. Questions? Now, most of you guys don't have dentures at home to play with. Some of you do, but most of you don't. So in our practice kits, we actually have denture simulators that you can use to learn how to do this skill. Comes in a denture cup. So our practice kits allow you to practice this skill at home. Oops. My mom actually makes those. Yep. We are a true family business. Should have seen it when I asked her, Mom, I want you to start making fake dentures for me. You want me to what? So we had some fun trying to figure out how to make them so that they were a good simulator for us. All right, so this skill is going to require 2 sets of gloves. One set will clean the dentures. The other set will clean the mouth the dentures came out of. So let me put this in terms that makes it a little bit easier for you to understand. If I were to brush your mouth, okay, if I'm going to have gloves on and I'm going to brush whatever's in your mouth, do you want me to use clean gloves or dirty gloves? Clean gloves. So if we've brushed those dentures, are those gloves clean? Do you want those gloves in your mouth? No. So we're going to brush the dentures, take those gloves off, put new gloves on to clean the mouth. That makes sure that we have clean gloves for our patient. Good. Now, some of you are going to ask, well, can't you do the mouth care first? Sure, you can. Absolutely. If you want to do mouth care first and then clean the dentures, go for it. There's no law that says it has to be one or the other. But if you do it that way, you then have to clean the basin twice. Once after the patient spits in it, and then once again after we finish the skill. So you can do it if you want to, but it does add an extra step for time. I'll show you why when we get there. All right. So there's 2 ways to clean dentures. We can clean them with toothpaste at the sink. That's what we're kind of used to, right? Same way you clean your own teeth. Just if you could take your teeth out and clean them, that's how we would clean them, is with toothpaste at the sink. But you can also clean dentures by putting them in a denture cup with those fizzy tablets. And in most cases, this is a better option because remember I said we use denture paste to hold those dentures in? Right? That denture paste is stringy, gritty, grimy. It'll get all caught up in the bristles of your denture brush, and it's going to be kind of hard to get all of that paste and all of those food particles off. So these denture tablets are specifically formulated to break down those proteins. So in most cases, this actually gets you a better clean. And then you just rinse them off before the patient uses them. Now, which method should we use for the test? Why? Care plan said, absolutely, absolutely. Good job. Yes. Cool water. Yep, cool water. So we're going to use a very specific brush to brush the dentures. Looks like this. This is a denture brush. One side looks like a toothbrush. We're going to use it on the teeth part of the dentures. Makes sense. The other side is smaller. It is specifically designed. It's tapered. You can actually kind of see it's like in a pyramid shape. It's tapered because it's specifically designed to fit in this channel. It fits in that channel. This won't get in there very well. It's going to miss areas. So that's why we use this kind of a brush. One side looks like a toothbrush for the teeth. The other side fits in the channel. So that's a denture brush. You could use a toothbrush if you want to, but for the test, they give us a denture brush, use the denture brush. And then when we clean the mouth that those dentures came out of, we're going to use something very specific. This is called a toothette, also known as an oral swab. But it's soft, it's spongy. We're going to use it like a toothbrush, dip it in water, put toothpaste on it. And the reason that we use this is because the patient's still going to have some denture paste in their mouth up against the gums. So it's going to hold food particles against the gums. If you use a brush, like a toothbrush, all of that denture paste is going to get all caught up in those bristles. It's not going to be that effective. When you use this, because it's a solid surface, you can swipe that denture paste away and turn it. Now I've got another surface to work with. So front, back, top, bottom, 4 sides. Good? Make sense? Okay. So I'm going to pass these around so you guys can see what the supplies look like for this skill. But that toothette, we're just going to wet like we wet a toothbrush, put some toothpaste on it, and then clean the gums. So we're going to prepare that denture brush before we put our gloves on. That keeps our gloves clean. So we'll wet the denture brush. Oops. We'll wet the denture brush, put some toothpaste on both sides, and now we're going to take it over to the sink. But we can't just lay it on the side of the sink. If we lay it on the side of the sink, it'll get dirty. So we have to have somewhere to put this denture brush while we're preparing to brush the dentures. So we're going to put it in that emesis basin. And just by laying it in the emesis basin, that's just a clean place to hold that denture brush until I'm ready to use it. So that's going to lay on the edge of the sink. Remember, you don't want your denture brush on the edge of the sink. You want it in a basin of some sort. We're going to put a washcloth in the bottom of that basin or bottom of the sink. That way, if we do drop those dentures, they're less likely to break. They'll actually go over the drain, that washcloth, and that's going to let the water pool up in there. When the water pools up, if we drop the dentures, they'll hit the water, not the sink. Less likely to break. When you're cleaning the dentures, guys, keep it over the sink. Don't start brushing over here over the sink and then just kind of turn around and keep it over the sink, because these dentures get very, very slippery with toothpaste and denture paste on them. They get very slippery. We're going to use a paper towel to turn the water on. Just like with getting water for bathing, use a paper towel to turn the water on. Get your washcloth in the bottom of the sink. Get everything ready and prepared. And then you can put your gloves on. Remember, the first thing your gloves should touch is the patient, in this case, the dentures. We're going to use cool water. And we're going to make sure that we keep those dentures in our hand. This was interesting to me. I'm going to kind of digress for just a second. A couple of years ago, so I go to something called the HOSA State Leadership Conference every single year. This is the Health Occupation Students of America. So students that are going to high school programs, college programs, vocational programs, most of them belong to HOSA. It's a student organization. And every year in Orlando, they have a competition where you can win scholarships and prizes and all kinds of stuff. Well, I go to the State Leadership Conference every year because I'm their celebrity guest. It's a lot of fun for me because I get to connect with students that have been watching me on the screen for their entire year. Well, 2 years ago, I actually judged a competition, because they get scholarships and stuff. And I never really stopped to think about the effect me being there judging would have on the students that have been watching me on the screen. Well, they all freaked out. Oh my gosh, Miss Patty is judging. That's not good. They all freaked out. And the event I was judging was this one, denture care. And the care plan was even more simple than this one, even more simple. But it amazed me how many students during the judging put those dentures in the sink. Just set the dentures down in the sink while they were getting stuff ready. And I'm thinking, would you want those dentures in your mouth after they've been in the sink? Probably not. So every time I give this lesson, I think about that. You know, when you're taking the test, I want you to think to yourself, if I were the patient, would I want that done? If you kind of keep that in mind, if you think about, if this were your very favorite family member, how would you do the skill? You'll do great. Does that make sense? Sometimes we get so caught up with the technical aspect of what we're doing that we kind of forget why we're doing it. Okay. I don't judge anymore because of the effect I had on the students. I felt awful. I never even thought about it. I felt awful, but I really derailed them because they weren't expecting me to be judging them. So I don't do that anymore. All right, so the first thing our gloves should touch is the patient, or the dentures in this case. Now you're just gonna brush whatever's there, top, bottom, front, back, groove. Just brush it. There won't be anything on the dentures. They're just like the ones I passed around. They're clean. They've never been in anybody's mouth. There's nothing to brush off. There's no paste. It's just empty dentures. But do a good job. Get all surfaces. They are looking for that. Keep them in your hand over the sink. Make sure you're wearing gloves when you're touching the dentures. Don't touch dentures without gloves. That's just gross. And then once you get those dentures clean, we're going to dump that cup out, fill it up with cool water, and put our clean dentures in the clean cup filled with cool water with the lid on. But that cup is now wet. You just dumped water out of it. You've rinsed it out. You put clean water in it. That cup is wet. Do you think we want to put a wet cup on a surface like this? What would happen? What would grandma say happen if you put a wet cup on a wooden surface like that, or a laminate surface like that? Yeah, it'll ruin it. It'll leave a ring. It'll warp it. So we need a coaster. Hold on one second, Betty. So we're going to use a paper towel as a coaster. So paper towel under the cup, put it on your bedside table. Betty says, when they say denture care, are they saying the person mouth care and denture care too? I'm confused on this. So Betty, you would want to go back to your care plan. And this care plan specifically says to clean the dentures and provide mouth care. So our care plan is telling us to do both. And that's why we're going to do both. Follow your care plan.
I think she's looking for clarification on, as far as denture care goes, do you always wash the dentures and the patient's mouth?
Yes, you should, ideally, because think about the patient's mouth, right? If we take dentures out, let's say I took these dentures out of my mouth, right? Well, what's still in my mouth is some of that denture paste and the food particles that those denture paste leftovers are holding against my gums. So you cleaning the dentures at the sink way over there doesn't do anything for the mess I still have going on here. So yes, when you clean the dentures, you should also clean the mouth they came out of to get those food particles off of the gums. I'll give you a great example of this. This is a horrible, go ahead and take that down. This is a horrible situation. It still churns my stomach. Years ago, I was a hospice nurse, and I went in to do an admission on a patient that had a brain abscess, and she was living in an assisted living facility. She had had a stroke. She was nonverbal, could not talk. So I go in and I'm doing the assessment on her. And It wasn't just a brain abscess that had encapsulated it. She was going to die from it, but her whole cheek was missing. Like everything here was just, it was missing. What happened to this poor woman? Well, she, because of the stroke, she wasn't able to move food around her mouth very well because she had, weakness on one side. So her tongue did not move food on this side of her mouth very well. And she had dentures, and somebody was taking care of the dentures, but nobody was doing mouth care on her. So she had pocketed food and denture paste over here that she couldn't really get out because of the stroke. And that food eventually, like it's going to, rotted and broke down, and it ate into her gum. Well, just on the other side of the gum is the sinuses. And just on the other side of the sinuses is the brain. So it actually tunneled the bacteria from this decomposing food, tunneled through her gums and sinuses into her brain. And that's ultimately what was going to kill her. But it also ate her cheek from the inside out. And that's when they found it. Was she had something that looked like a boil on her cheek. And then it just started necrotizing. I mean, that tissue died and then it just spread. And this killed somebody. This killed somebody. Killed somebody. That's horrible. So yeah, we should, if we're cleaning dentures, you should always clean the mouth they came out of. And especially important if you've got somebody with dementia or with a stroke that cannot move food around very effectively. That's horrible. I feel so bad for her. I mean, that was probably about 10 years ago. I still think about that. Because what a way. I mean, we all have to die. Nobody's getting out of this alive, right? Everybody's going to die. But there are ways that I do not want to die. And that would be pretty high on my list. So once we're done cleaning the dentures and they're in the denture cup, in cool water, on a coaster, on the table, we can get rid of that washcloth. We're done with it. Wring it out, put it in dirty linen. And then we're going to come back over to our table with our basin holding that clean denture. You clean off the denture brush. So now we're back at the table. We still have our gloves on. We're back at the table. We got a basin with a denture brush in it. And we got everything else we need to do mouth care. But I know the patient's going to have to spit in that basin for mouth care. So I need to take that denture brush out and put it on the barrier. And I want to do that with my gloves on. Remember, that denture brush has had saliva and stuff on it. So with my gloves on, I'm going to take that denture brush and put it on the table. Now I'm going to take my gloves off. I'm done with the dentures. Now that I'm done with the dentures and I've taken my denture gloves off, I'm going to wet my toothette, put some toothpaste on it, get my towel on my patient, and be ready to go for mouth care before I put my new set of gloves on. Do you guys understand why? So we clean the dentures. We put them in a cup with cool water on a coaster on the bedside table. We put our washcloth in dirty linen, and we bring our basin holding our denture brush to the table. Take the denture brush out of the basin and put it on the side. Take your gloves off. Dirty gloves. Don't touch any clean stuff. Dirty gloves. Now, no gloves. Dip your toothette in the water, put some toothpaste on it, put it in your basin just to hold it. Put the towel over the patient and then put your new gloves on. Now we're ready to brush. Brush whatever they got. They might have some teeth in there. They might have some missing areas in there. I don't care what they've got. Brush it. And then let them rinse and spit. Use that towel to dry them off. And then we're just going to clean up our environment. So your towel goes in dirty linen, your basin gets cleaned the way everything else gets cleaned. Store it. Make sure your work environment is clean. So these are our skill-specific steps. Remember, we still have to do our opening, right? You still have to get a barrier. All of those things, don't hold your linens against your uniform. All of these things still apply. But let's look at skill-specific. We're going to put a washcloth in the sink. We're going to keep the denture in the cup, basin, or hand. Don't put the denture down in the sink. So it needs to be in the denture cup, in your hand, or you can put it in the emesis basin if you need to. We're going to use cool water. We'll brush and rinse all surfaces of the denture. We're going to store that clean denture in clean water on a barrier on the bedside table. We're going to protect the patient's clothing from mouth care. And we'll brush all surfaces of the patient's mouth. Let them rinse and spit. Leave their face dry. And then make sure that all of your dirty linens have been put into dirty linen. Don't leave them on the overbed table. Good? This is the hardest skill for students. This is the one that you will struggle with the most because there's two parts to it. There's cleaning the dentures and then there's doing mouth care. And students get all mixed up in how to transition from cleaning the dentures to doing mouth care. This has part A and part B, and it's complex for students. I'm going to tell you, they aren't grading on any of that. They don't care when you change your gloves. They don't care what you are touching. They aren't grading infection control. I need you to understand it because someday I will be the body in the bed. But they're not grading you nearly as harshly as you think they are. Brush the dentures, keep them over the sink. Make sure you have gloves on and use cool water. Store them in cool water. Brush the patient's mouth. If you can get those things done, you will pass this skill. Good? Good? All right, let me show you the video for this one.
Hello,
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing good. How about yourself?
Wonderful. I need to do denture care on you. Is that okay?
Yes.
I'm going to take your dentures to the sink. I'm going to close the privacy curtain and wash my hands. I'll be right back.
Okay.
Okay, Mr. Jones. I'm going to place a barrier on the table so we have a clean area to place the clean supplies. And then I'll gather the supplies that I need. We'll need a cup of water, a toothette, a denture brush, toothpaste, a basin, a washcloth and a towel, and 2 sets of gloves. Okay, we're going to get the denture brush ready for use, so I'll wet it and apply a little bit of toothpaste to both sides. We'll allow the basin to hold that denture brush until we're ready to use it. I'll be right back, Mr. Jones. I'm going to go clean your dentures.
Okay.
Okay, Mr. Jones, I'm just going to set your dentures over here so that you have them if you should need them later.
Okay.
I'll place the denture brush on the barrier, and now we'll remove these gloves. And we'll throw those away. Do you mind if I place a towel over your chest?
That's fine.
This will help keep your clothing clean.
Thank you.
We're going to prepare for the mouth care portion of this skill. We'll take the toothette and wet it. Apply a little bit of toothpaste to one area of the toothette and apply gloves. Okay, Mr. Jones, I'm going to brush all surfaces of your teeth now. So in a moment, I'll need you to open your mouth wide so that I can reach the back teeth.
Okay.
Okay, can you open your mouth? Thank you. I'm going to brush the back on the bottom and on the top, both sides. Okay, can you bring your teeth together, please? Thank you very much. We're going to throw the toothette away. And would you like to rinse? Very good. Would you like another rinse?
Yes, please.
Another rinse?
No, thank you.
Okay. I'm going to remove your towel and we'll place this in dirty linen. We'll throw away the disposables. And now I'm going to clean your basin. I'll be right back.
Okay.
I'll place the denture brush and the toothpaste in the basin and open the drawer with a paper towel to store the basin and other supplies. I'll remove the barrier from the table and we'll throw this away as well. Now I can remove my gloves. Mr. Jones, are you comfortable?
Yes, ma'am.
Can I get you a magazine?
No, thank you.
Is there anything else that you need?
No, thank you.
Your call light's right there. If you should need anything, just let me know. I'm going to open your curtain and go wash my hands.
Thank you.
After washing my hands, I'll think about the steps of my skill, make any corrections, and then tell the evaluator my skill is done. Any questions? Any questions? No? Okay. Please be aware that I make that one look very easy. I make it look seamless. You're watching that going, why is she saying that's the hardest one? When you start to practice this, you'll get tangled up. You will. So try to keep that in mind as, you know, as you're practicing. This is one that you really should practice. If you don't have anything to practice on at home, get just pick something out of, you know, out of like a carrot stick or something that you can just kind of practice brushing, you know, as a stand-in for the dentures, because they don't have to look like dentures for you to practice on. Celery works. Doesn't have to be a horseshoe shape because celery has the groove.
Or you can use like that. I don't know if anyone has like a little brother that plays football. But
A mouth guard. Yes. Yeah. During Halloween time, I tell people to go out and get the fake vampire teeth or the hillbilly teeth. Those work too. You know, you can get a little creative when you're practicing these skills. All right. We have 2 more skills to learn today. Both of them are a little bit on the longer side. Well, ambulate is a short skill, but the lecture I have to give you is a little bit longer. And then we're going to learn partial bed bath today. I thought it was on Wednesday, but it's actually today. So I'm going to explain the whole washcloth thing that we were talking about earlier. So that's got a little bit of a lecture too. You should have about a half hour to 45 minutes of practice time built into class today. On Wednesday, you'll have a little bit more, closer, 45 minutes, closer to an hour, something like that. So let's go ahead and take our break. When we get back from break, we'll do the last 2 skills and then you'll have some practice time today. Okay? All right.
oh, so we're gonna be hands-on too.
Yep, you've got some practice time today. All right, go ahead and take your break. All right, so we talked about the practice kit a little while ago. So those of you that are joining us online, please know that we do have a practice kit available that has everything in it that you need to practice all of the skills that you're learning in here for the CNA exam. So one of the skills that we're about to cover is ambulate with a gait belt, and we actually have a gait belt in the practice kit, along with everything that you need for denture care and all the other skills that we're going to be learning. So the next skill that we're learning is ambulate with a gait belt. Yeah, I am live. Okay. Ambulate with a gait belt. Ambulate is just a fancy word for walk. So we're using a gait belt to help somebody walk. That's it. It's not a hard skill. It's not a long skill. But there's a couple things that we have to go over to understand what they're testing us on and how this is going to relate to our patients specifically. So what I want to talk to you about right now is going to start on page 63. And we want to talk about energy conservation. And this is a really hard topic for students to get without something kind of practical to tie it to. So have you ever seen a 2-year-old? 2 and 3-year-olds, those are my favorite humans on the planet. I love 2 and 3-year-olds because they're just starting out on independence, right? 2 and 3-year-olds, anybody know what their favorite word is? No, that is correct. Favorite word is no. Now, there's a reason that no is their favorite word. And it all has to do with establishing independence. So this is the first time that they learn cause and effect and body autonomy. So this is something you all take for granted. You all know that if you say no, no means no, right? You have body autonomy. But we have to learn that. And around 2 or 3 years old is actually where we start to develop autonomy. So that's why no is the favorite word of a 2-year-old, because they're learning the power that that word has. Love that age. It's amazing. And if you understand child psychology, or if you understand what goes into that, you'll actually relate to your 2 and 3-year-olds a whole lot better because you'll stop seeing them as being contrary. And you'll start noticing that they are learning about their own limits, their own autonomy. So it's a really fun age. But the other thing about 2 and 3-year-olds is physical, their energy levels. So now energy levels are high at 2 and 3 years old. And we've all said it, you know, oh my gosh, if I could just bottle that energy, I'd make $1 million, right? So we all know kind of intellectually that, you know, kids have a lot of energy. But I want to make this a little more specific. Have you ever tried to explain to a 2-year-old why you do not have the energy they have? They don't get it. They just don't get it. They're like, come play with me, come play with me, come play with me. And you're like, no, there's no energy. I'll sit here, I'll watch, right? You can't get them to understand because they have no frame of reference. They think everybody has the same energy levels that they do because that's all they've ever experienced. Make sense? Well, what's interesting about this is that that is the highest amount of energy that you have in your lifespan is when you're 2 to 3 years old. And it's all downhill from there. We don't think about it that way, but it's true. This is the highest level of energy that you will have in your lifespan. So let me, 2-year-olds will jump up and down for no reason. They don't have to have a reason. When was the last time you jumped up and down? Probably when you were 2. Now, I will jump up and down if I win the lottery, right? But I have a reason. Adults don't just jump up and down for no reason. We don't have the energy to spare for that kind of nonsense, right? So we have to understand there's a huge amount of energy here. I mean, they're trying to blow off energy, literally. But it doesn't stay that high forever. In fact, in just 10 short years, they have dropped in energy levels. Now, 12-year-olds still have a ton of energy. They can skateboard, play video games. They still have a ton of energy. But you put that 12-year-old in charge of that 2-year-old for one afternoon, who wins? 2-year-old. Absolutely. The energy levels have declined. Now, let's go out to 22. 22-year-olds will shop till they drop and go out at night looking fabulous, still tons of energy. But you don't have the same energy level you had when you were 12. Let's go out to 42. Now, 42-year-olds, we're shopping till we drop, but that's at like 3, and we're not going out tonight. 62. Our energy levels have dropped so much that we're now putting our feet up for 10 minutes before we make dinner. We're starting to think about things like retirement because we don't have enough energy to do all of our daily household tasks as well as work. Energy levels have dropped. What do you think they're going to be like at 82? Very low. But do you remember when you were trying to tell that 2-year-old that you don't have energy and they just didn't get it because they have no frame of reference? When this 82-year-old tries to tell you that they don't have the energy for something, you're not going to get it because you, like that 2-year-old, don't have a frame of reference. And this is where CNAs get into trouble. Miss Marcia, I need to give you a shower. Oh, honey, I don't have the energy for that. What do you mean you don't have the energy? All you got to do is sit there. I'm doing all the work. What do you mean you don't have the energy? Honey, I don't have the energy for that. Well, you don't listen to her, just like that 2-year-old, right? You assume she has the energy you do. You have no frame of reference. You tell her, Miss Marcia, you got to get a shower. I'm going to put you in the shower. Not understanding that just the actions associated with this are taking energy. So she meant she didn't have the energy. And yet we don't want to hear that because we're still way up here. We assume the energy levels are going to be the same, and they're not. So let's talk about energy. Let's talk, because it's a big topic. Let's talk about energy. What things do we do every day that take energy? That takes half of my energy every day. Yeah, getting up out of bed. I like my bed. It's comfy, it's warm. I don't want to do anything. Just getting up takes energy. Now, what else do we have to do? Okay, work. But before we even get to work, what do we have to do? Yeah. What's the first thing you do when you get out of bed, most people? Bathroom. Bathroom. We got to go. We got a full bladder. We got to go. Right? We usually get some coffee or something into us, you know, to get us started. You have bathing and grooming and dressing that you have to do. You probably have some eating in there somewhere. And then getting yourself to wherever it is that you're going to go. Work, school, errands, whatever. You have a lot of things that you have to do every day just to exist. Just to exist. Now, I want to go back here for a second. If this is all the energy we have, and we have to do all of these things, do you see how we could quickly run out of energy somewhere in there? You cannot look at the elderly with the same energy levels you have. It doesn't work. Make sense? Okay, so what do we do about this? Well, one of the things that I like to explain to students is, have you ever been too tired to blank? Have you ever been too tired to eat? Anybody ever been too tired to eat? Sure. Have you ever been too tired to talk? Mondays and Wednesdays, by the time I get home, right, because I have talked for 4 hours nonstop here. By the time I get home, I don't want to talk. I need a couple hours of quiet, please. I don't want to have conversations because I am tired. If you have ever been too tired to blank, it means that that action takes energy. Have you ever been too tired to shower?
Yeah, everybody.
Okay.
I've been so tired before, like,
Absolutely. Absolutely. Sure. I have been so tired I couldn't cry.
or like driving, you know. from
Oh,
camper,
yeah.
get tired.
So we have to think we go through a lot of energy every day. And when you have ever been too tired to blank, it doesn't matter how much somebody tries to talk you into doing whatever it is. If you are too tired, you are simply too tired. Make sense? Okay. So we have to start looking at our older patients and their energy levels when we start talking about doing skills with them. And this is going to take a little bit of rearranging of thoughts on our part. So let me show you, let me give you a visual demonstration here. So there is an inverse relationship between strength and energy. So if I'm super strong and I go to pick something up, it doesn't require a lot of energy because I have strength. If I'm super weak and I go to pick something up, it's going to require more energy. So there's an inverse relationship between strength and energy. Now, if you remember class 4, we talked about patients' strength decreasing with age. So we already know that our patients have less strength. Now, we just learned that they also have less energy. And if there's an inverse relationship between the two and we don't have much of either, we're in trouble, aren't we? So have you ever seen an older person try to get up out of a chair? Ever see that? Looks something like this, okay? Try to get up. We start to rock. We're building up that momentum. And then we,
Take the
no. Okay, hold, I'll get there. So we rock a little bit more. And then, how much energy did that take? A lot. Okay, so it took a whole lot more energy to do that than if I had just stood. Because I have the strength to stand, I don't have to use as much energy. Good. But because as we age, our strength goes down, we need to use more energy just to simply get up out of a chair. Well, why do we care? Well, let's go back here. If we are getting up out of the chair, well, if we're getting up out of bed and it takes that amount of energy, and then we have to get to the bathroom. So we walk to the bathroom, we sit down, and then we have to use energy to get up. And then we walk to the chair and we sit down to rest. And then we have to get up to brush our teeth. So we walk to the bathroom and brush our teeth. We come back and we sit down in the chair. And then we have to go get dressed. We get up out of the chair to pull up our pants and get dressed. And then we sit back down to rest. And then we have to go eat breakfast. So we get up out of the chair, we go eat breakfast, and we sit down at the table to eat breakfast. And then we have to get up. And then we come back to our chair and sit down to rest because we're worn out now. It's only 9 a.m. Every single one of these is going to require energy on their own. But if it takes that much energy just to get up, we're going to run out of energy by the end of the day. Probably before the end of the day. So what do you think is going to happen to tomorrow's energy levels if I am too tired to eat this afternoon? I'm going to be weaker. I'm going to be weaker. And this can start a downward decline because we've used up all of our energy. Do you see how important this topic is? So as a CNA, we can use some of our strength to offset their energy requirements. So instead of having this patient work so hard to get out of this chair, we can help them by giving them some of our strength to stand up once rather than rock back and forth, fall back, do it again. So strength, remember, and energy is inverse. So if we give them some of our strength, it takes less of their energy. That's what gait belts are all about, is allowing us to lend them some of our strength. Now, you will see some people, though, that don't use gait belts. They'll grab the patient's arms, the back of the arms, and help lift them to a standing position. Well, you kind of have to look at how a body is stacked, basically. Most of our weight is in the bottom part of our body, not the top part, not head and shoulders. Most of my weight is down below the level of my shoulders. So if I'm grabbing at the shoulders to lift somebody up, like at the back of the arms to lift somebody, the rest of this is going to be trailing behind, which means I've got to use more force, more of my energy. But I also have to grip tighter and pull harder. What could that do to our patient's arms if we're gripping tight and pulling hard? Yeah, we can damage their skin, bruising, skin tears, ripping. We can also affect their muscles or nerves, or even in some cases, bones. You can dislocate. So grabbing somebody at the back of the arms and lifting them that way is not good practice. So somewhere along the line, somebody says, hey, if most of their weight is toward the bottom, it would make sense to lift them toward the bottom, right? So we're at the center of their gravity, which is a great train of thought, right track. But if we are not using a gait belt in order to make that work, we have to grab their pants and we lift them using their waistband of their pants. Anybody ever have a wedgie? Because they'll move. Oh, they'll move quick. But they're moving not because you're helping them, but because you're hurting them. We're giving them a monster wedgie. So grabbing them by the back of the arms does not work. Grabbing them by the pants to lift them can actually cause injury. Yeah, so those two are not good solutions. The solution here is a gait belt. So a gait belt is put on over the patient's clothing at their waist, secured so it doesn't move. And then we're going to use that belt to help our patient stand up using some of our strength to offset their energy requirements. That's what a gait belt is all about. A gait belt does not prevent falls. A gait belt used correctly can clue you into the fact that your patient is unsteady and you can take an action to prevent a fall. But the gait belt itself will not prevent a fall. It is not used for safety. It's used for strength. We're lending some of ours to our patients. Does that make sense? You guys understand gait belts a little better? Okay. All right. So our skill for this is ambulate with a gait belt. Ambulate is just a fancy word for walk. So down the side, you'll see the principles involved in this particular skill. They're all spelled out here. For the test, this skill should take somebody with your level of experience, 5 minutes or less. Live testing students sitting in a chair for this skill. Documentation is not required. But in order to do this skill, we have to learn the last principle. So we're halfway done with class, guys. Actually, a little more than half, because you only have 3 classes left after today. You remember way back 2 weeks ago when you were sitting in this classroom and I told you you're going to have to learn everything on that back wall. Your eyes got about this big and you're like, oh my gosh, that's a lot of work. You now know everything on that back wall except for this. I want you to take a minute to soak that in. It should not have been hard for you to learn these principles. But I know you know them because we just reviewed them. And you told me what they were. So I know you know them. So we're going to learn this one. Now, this is the last one that we learn because this one can be the most difficult for you guys to kind of understand. Okay. Remember, you are the 2-year-old in this scenario. We have to somehow get you to understand an 82-year-old. So let's talk about shoe rules. Our care plan at the top of page 67 tells us to ambulate the resident at least 10 steps. Guys, it's round trip. So 5 steps in one direction, 5 steps back. That's it. That's all we're doing. I'm walking somebody 5 steps, turning them around and walking them back 5 steps. That's the skill. Put an opening in front and a closing behind. Doesn't take 5 minutes to do this. Less than a minute. But you have to know what we're doing and why we're doing it. And that's what's going to take us some time. Tells us to use a gait or transfer belt. Same thing. Remember, everything in medicine has at least 2 names. We talked about that, right? Gait belt and transfer belt. Same thing, 2 names. Patient will be sitting in a chair at the side of the bed with their shoes on. So you don't even have to put their shoes on. Patient is able to walk, but needs assistance to stand. So that rock and roll method I was just talking about, we're going to use some of our strength so that they don't have to do that and conserve some energy. But let's learn shoe rules. So the first thing that we need to understand are slipper socks are not enough. Slipper socks are not enough. Anybody ever been a patient at a hospital? When you go into a hospital, they give you a patient gown and some slipper socks, and we all put them on because, hey, they're cool. We get to take those socks home with us. We get all excited. I don't know why. Free socks. They're not free. You're paying for them. But we walk around in these things. Think about all the places you walked in that hospital with those slipper socks. And then you got back into bed with those slipper socks on. What got back into bed with you? Oh, all of the pathogens. All of them. All of them. Housekeeping does a pretty good job, guys, but they're not going to eradicate every pathogen that's in that hospital. Slipper socks should not be worn outside of the bed without something covering them. Slipper socks are not enough. We have to have shoes on. Now, I have a whole lecture for this. Unfortunately, because I didn't get the slides done, the lecture is in a different lesson that you guys, so I've got to do this all manually without, use your imagination here, okay? I don't have slides for this. But in order to understand this, we have to talk a little bit about diabetes. I have diabetes in here. Do I have diabetes in here, Jake? No, I don't. Okay. I don't. Okay. Emeralda, thanks a lot. I passed the state exam last Tuesday. Congratulations. Congratulations. Great job. Okay. All right. So let me explain this because we don't have this up here. One of the reasons that slipper socks are not enough, that we need actual shoes on when we're walking a patient, they have to have something hard soled on their feet, is because of diabetes. In order to understand why, we have to talk a little bit about what diabetes is. Now, this is a 5th grade version, guys. This is super simplified. There are people that study diabetes throughout their entire career. I mean, 10, 12 years of instruction on diabetes. It's super complex. I'm going to simplify it. Every cell in your body needs fuel to run. Every cell. And the fuel that they prefer in most cases is sugar. Sugar gets a bad rap in our community. Sugar is not bad, guys. Every cell in your body needs it. Now, when you eat carbohydrates, carbs, they break down into sugar. And that's a good thing because every cell in your body needs sugar. It's a win-win scenario. It's awesome. The problem is when we eat carbs in excess. So if we eat carbs, they break down into sugar. Sugar goes into the cells. The cells are happy. They do what cells do, and life is good. If we eat carbs in excess, whatever the cells don't take in, whatever the cells don't use, we can't get rid of it. We don't excrete excess sugar. It'd be nice if we did, but we don't. We're not set up that way. So what happens is your body is going to package up that excess sugar. It actually puts it in a little cardboard box, some packing peanuts, put some tape on it, and makes it into something called glycogen. That glycogen is going to go into a storage unit just in case we might need it at some future date. Because I don't know what your sugar level is going to be like 10 years from now. So let's pack it away for future use. Now, these storage units are fat cells. So you eat carbohydrates, breaks down into sugar, sugar goes into the cells, fuels the cells, anything excess gets packed away and put into a fat cell for later use. Anybody ever watch that show, Storage Wars? Anybody familiar with that? You know, when you go bid on these storage units that people quit paying on, and you might get a great one, full of Aztec gold or something, but they never do. They're all like full of 70s shag carpets and lava lamps and stuff nobody wants anymore, right? Well, that's kind of like your fat cells. We put these boxes in the fat cells for future use because we might need them at some point, but they don't age well. It's kind of like lava lamps. They just don't age well. If you're in the 70s, lava lamps are a thing. If you're now, lava lamps are a little retro, right? So the glycogen that's stored in our fat, this is why it's so hard to lose fat, because the glycogen doesn't work as well as it did when it was first put in. It doesn't age well, and it's hard for us to use it. Make sense? Okay. So that's kind of how metabolism works in the body. Now, the thing that I haven't talked about is how does the sugar get from the bloodstream? You eat carbs, they break down into sugar. That sugar has to go in the cells. How does that sugar get from the bloodstream into the cell? Because the cells are actually locked. There has to be a key to open that cell. And that key is something your body makes called insulin. So you eat carbs, those carbs break down into sugar, and the sugar goes into the bloodstream. That triggers your brain to tell your pancreas, hey, we need some insulin. Pancreas cranks out a hormone called insulin. Insulin then opens the cells and allows the sugar to go in. That's what we call normal metabolism, energy metabolism. And that plays into this because it's a whole energy thing. Okay, so keep that in mind. I'm going to go somewhere with that. Now, when we have diabetes, what's broken here is the key. So you eat carbs, they break down into sugar. That sugar goes into the bloodstream. The brain tells the pancreas, we need some keys. And the pancreas is like, nah, not today. Or, hey, I made you some keys, but it made some house keys. We need car keys. Wrong keys. So either the pancreas isn't working or it's not working properly, one or the other. And I'll explain how we get there in just a minute. So now we've got sugar in the bloodstream that can't get into the cells. And remember, we can't get rid of excess sugar. It has to be packed away. So now this sugar is circulating. So it can't go into the cells. It's just circulating because it has no keys to open the cells. Now, unfortunately, the cells need fuel. They're hungry. So the cells start screaming at the brain, I'm dying here. Literally, I have no fuel. I am dying. You need to get me some fuel. So the brain triggers a craving. Anybody know a diabetic? What do they crave? Sugar. The whole reason they crave sugar is because their cells are starving, legitimately starving. So the brain is like, oh my gosh, you're starving. We need sugar on board. So it triggers a craving. And this is why your diabetic patients get cravings for sweet stuff. It's because their cells are dying. Now, the problem is that they can eat all the sugar in the world. It's not going to solve the problem that the sugar is not getting into the blood or the cells. It's staying in the bloodstream. See how that could be a problem? Okay. So you guys have a basic understanding of diabetes now, diabetic process. So we eat carbs. Those carbs break down into sugar, go into the bloodstream. The brain tells the pancreas, create some insulin, and the pancreas doesn't. So now that sugar just stays in the bloodstream. It will go into fat cells, be packaged up as glycogen and go into fat cells, but eventually we run out of storage units. So it just stays in the bloodstream, circulates. And this is how we get high blood sugar. Connect those dots. Okay. Now, this doesn't happen overnight. Estimates are within the next 5 to 10 years. And I don't have the stats right in front of me, but it basically the time frame is about right. About 70% of our over 70 crowd will have diabetes. This is not something that just happens overnight. It's not something you can catch. This happens in childhood. We just don't see the effects of it until later in life. So let me explain. So we have a small child, 5 years old, gets up in the morning, 5 o'clock in the morning. Mom's like, oh, it is way too early for this nonsense. So turns on TV, cartoons or something for the child. Mom collapses on the couch and kind of takes a little cat nap, right? Where they're kind of listening, but not really engaging. But that child is hungry. So mom's not ready to, exist yet. So gives the child a Pop-Tart. That Pop-Tart is carbs. Those carbs break down into sugar that goes into the bloodstream. And because we have sugar in the bloodstream, the pancreas has to produce insulin. Mom wakes up about 7 o'clock and gives the child a proper breakfast, cereal. And kids aren't eating all bran or shredded wheat, are they? What do kids eat? Oh, Captain Crunch, Fruity Pebbles, Trix, all the good stuff, right? Cookie Crisp. We even have a Cookie Crisp. So that's sugar. Even the milk is a form of sugar, galactose. That sugar breaks down in the bloodstream, and the pancreas has to produce insulin to get it into the cells. So mid-morning snack, mom's a good mom. She gives the child some fruit, which is fructose. Anything that ends in an OSE is a sugar. So the child eats the fruit, it breaks down into sugar, and the pancreas has to produce insulin. Lunchtime comes around, national toddler diet of chicken nuggets and mac and cheese. And yes, the chicken has a little protein, but most of it is carbs. And those break down into sugar, and the pancreas has to produce insulin. Afternoon snack, Little Debbie something. That is sugar that causes the pancreas to produce insulin. Nighttime, we have spaghetti with salad. Kids not going to eat the salad, but they do eat the spaghetti, probably with ranch, which is a weird combination. But those are carbs that break down into sugar, goes into the bloodstream, makes pancreas produce insulin. And then, of course, we have to have dessert before bed, which is a sweet, generally speaking, that breaks down into sugar, prompts the body to produce insulin. Do you see how much work that pancreas had to do? That is one day out of the American diet. That is not the exception. That is the rule. So we overwork our pancreas in America just by our eating habits because we take in carbs in excess. Every carb you take in makes your pancreas work. Make sense? So we overuse our pancreas. And by the time we get into our 60s and 70s, pancreas is like, I don't know what to tell you. You overused me. I'm just not doing anymore. I'm done. I'm on strike. I am done. Done. And it quits working properly. So this is how we end up with a very, very high level of diabetes in our older population. And they'll tell you, I didn't have diabetes 5 years ago. What happened? Well, what happened is your eating habits throughout your lifetime have caught up to you now. Make sense? So if you guys, because you're young, are aware of this, you'll start paying attention to how much you're making your pancreas work and maybe be able to prevent. Yeah. Prevention is always better. Make sense? Any questions on how that works? Okay, there is something that we can do for our patients though, and this is super important because CNAs are going to help patients with snacks, like in between meals. And you're also going to be encouraging patients to eat. Well, remember I said that every cell needs sugar to run on, right? So we eat carbs, they break down into sugar, we have insulin, insulin opens the door, the sugar goes in, everybody's happy. Well, with diabetics, they don't produce the insulin. So if they eat carbs, it's not really going to help them. But they get these cravings. So they eat sweets because their brain is telling them you're going to die if you don't. It is that serious in their head. They eat sweets, but those sweets aren't going to help them. However, on the backside of each cell is a little teeny tiny door, right? The big door is the sugar door. That's the one we want to open, but we don't have any keys. But on the backside of the cell is a little bitty back door. And that door can be opened with protein. So if we have a diabetic patient that is eating a handful of M&Ms, try to get them to eat some protein with it. And that protein is enough to open the door a little bit to allow some sugar in, so those cravings get reduced, the cells get fed, and everybody is happy again. So when we have a patient that's diabetic, we generally combine protein and carbs together. So apples and cheese, a half a tuna fish sandwich, peanut butter crackers. So we're combining the carbs for the sugar, but also the protein to open the cells. And that helps reduce cravings overall. Make sense? What you don't want to do is chastise a diabetic patient for eating sweets. And a lot of CNAs do this. You're diabetic. Don't you know any better? You cannot have sugar. What are you trying to do? Kill yourself? What are you, an idiot? I mean, CNAs will do all kinds of really gross things to try to help their diabetic patients, and that does not help. Do you think that makes any difference to those cells that are starving? No. So instead of berating your diabetic patients for not knowing any better or making the right choices, it's better to say, hey, I see you're eating some sweets. Your cells must be in trouble. How about some protein to go with that? And that'll calm that craving down. If we start helping our patients with these types of issues, we can help their overall health and their eating patterns. Good. So for you guys that are still young and still healthy, a good rule of thumb is eat half as much protein as carbs for every meal. So if you want that large fry from McDonald's, you have to eat 2 chicken breasts. Now, not the bun. You can't have the buns, just the chicken breasts. So if you want the large fry, you got to eat 2 chicken breasts to go with it to balance out those carbs. You're starting to see that the medium fry might be a better option. Then I only have to eat 1 chicken breast. Now, if I want the bun too, I got to make some other cuts somewhere else. So if you start to maintain that ratio, half as many protein grams as carbs, it'll keep you in balance.
So it's not bad to have like bread and fries. And
Carbs in moderation are a good thing. They keep your cells running. Carbs,
I kind of like cut it out. My mom told me it's okay to like have rice sometimes.
carbs in moderation are good. Yep. Now, if you want to unpack those storage units that your body has, you know, the fat that we've stored, then you have to cut out carbs. Because your body, as long as it's getting a fresh supply, it'll never go into that storage unit to unpack any of the carbs that are in it. Why would it? It's got some fresh. We would only go into those storage units if we don't have any fresh coming in. So if you want to get rid of fat, we stop eating carbs. Does that make sense? Okay. It helps when I have graphics. I'm sorry. But if you want to get rid of fat cells, use up what we have stored in those fat cells, we have to stop eating fresh carbs or increase our energy consumption, which produces the need for more sugar in the cells. So we either move more or eat less. There's really no way around it. I know injections are out there. I get it. But ultimately, that's what we want to do is get our everything back into balance. Make sense? Good? Okay, so why do we care about this? Sugar is a crystal. That's a crystal. See what that looks like? See how jagged those edges are? Do you guys see that? Pretty crystal. I actually grew this. Pretty crystal. But crystals are jagged. Now, sugar in your system is just like this crystal. It's hard. It's jagged. Well, have you ever seen like a cake or a cupcake that has frosting on it, right? That's sugar, right? Sugar, powdered sugar, sugar. What happens when you leave that cupcake or that cake out for a couple of days on the counter? Okay, it gets hard. That's right. So that's exactly what it is. These sugar molecules get hard. They harden and they get all the sugar and the oil separate. So when we have these sugar crystals circulating in our bloodstream, because they have nowhere to go, they can't get into the cells, they're just circulating, they're going to coat the inside of the arteries over time. And that means we have a whole bunch of stuff on the inside of our arteries that's going to catch everything speeding by. And this is what ends up happening. So when we're young, our arteries look like this. This is a beautiful artery. This is gorgeous. It's wide open, lots of room to move around, but our arteries don't stay like this. As we age, they start to get a buildup. And if you look close, you can see the inside diameter of this is smaller than this. Each of those layers has thickened. This is normal aging. Normal aging. But you can also see we've got just this little kind of buildup here of plaque. If we don't address that, we end up with arteries that look like this. Not much blood is going to get through there. We've taken up about a quarter of the space that we had to work with. Now, the one thing you need to understand is when blood slows down or it stops, it clots. You see this every time you cut yourself. When blood slows down or stops, it clots. So if we restrict the area blood has to get through, it's going to slow down. If the restriction gets too bad and we stop the blood, what is it going to do? Clot. So patients with severe obstructions, this is called atherosclerosis, are at risk for blood clots. You guys see that? You see how that happens? Well, how does this buildup occur? Well, you've got crystals that line the inside of the arteries because they have nowhere else to go. And because they're sharp, they pick up anything that's speeding by, like cholesterol, which looks like pizza cheese in your artery. So now you've got these hard, spiky crystals with pizza cheese all wound up in there. And then you've got platelets and white blood cells and red blood cells that get shredded by these crystals. So you end up with this big, goopy, gluey mess. That's no good for anybody. Now, the real problem here is that on planet Earth, we have gravity. And gravity pulls heavy things down. This is a heavy thing. And it pulls it down. What is the lowest point of my upper body? What is the point of my upper body that's closest to the floor? My hands. What is the lowest point of my lower body? My feet. So diabetics tend to have more problems with their hands and their feet because these crystals get pulled down into these little tiny blood vessels, which get all gunked up. And this is why we do hand and nail care and foot care. Good? Make sense? But there's another problem with diabetes. It doesn't just affect the, there we go. It doesn't just affect the arteries. It actually affects the nerves as well. So like it coats the inside of the arteries, it actually coats the outside of nerves, and it can prevent a signal from being transmit. So if I stub my toe, there is a nerve from my toe that connects to the nerve in my leg, that connects to the nerve in my back, that goes to my brain to say, hey, we stubbed our toe and that hurt. It's a wired system. But if I have corrosion on that wire, if I have a lot of sugar, my toe knew that I stubbed it, but it can't get the signal to my brain. The connection is lost. Does that make sense? So let me give you an example of why this affects patients. So I'm going to talk to you about Henry. Henry is a real patient that I saw about 20 years ago. Names have been changed to protect the innocent. Henry was in his 50s. Now, I was an agency nurse. It's a substitute nurse, the type of nurse that doesn't work at the facility. I'm, called in when they don't have enough of their nurses. So I was an agency nurse. I went in and I was assigned the rehab side. So these people are only there for like 6 weeks and then they go home. So the focus is on getting them better. And I went in to see the patients room by room. And I walked into one specific room and the light was off in the room. There's just a very small light just above the bed, just a very small fluorescent light. And so I walk in and I flip on the light and the guy starts yelling right away, turn it off, turn it off. I mean, he's like really dramatic. So I turned the light off and I walked up to the bed and I said, hey, Henry, I'm Patty. I'm your nurse today. And I need to do a head to toe assessment. I've got your pills here. And he's like, do what you got to do. And he was really gruff. He was in his 50s, but he was like ex-military. And he's just, have you ever seen those types of guys? They're just like no nonsense, right? Really gruff. So as I'm standing there talking to him, I'm catching an odor. If you've ever smelled a wound, they're very distinctive. And I'm smelling a wound. So as we're talking, I'm pulling out my report sheet and I'm just kind of looking at it. And there is nothing on there about a wound. There's no wound care orders. There's no assessment orders. There's nothing about a wound. Crap. So I say to him, hey, Henry, I think you might have a wound brewing somewhere. Can I take a quick peek? He's like, do what you got to do. So I looked at all the usual suspects, the tips of the ears, the back of the head, the shoulder blades, the lower back or coccyx area, the hip bones, the back of the legs, get all the way down to his feet. And he's got those slipper socks on. And I said, hey, Henry, can I take your socks off? And he immediately shouts, no, leave my feet alone. Okay, well, there's a red flag. So I sweet talked him because you can always get further with patients by being nice than being mean. So I turned up the charm and I got him to agree to allow me to take his socks off. I took one sock off, the right sock, and it was fine. I mean, the foot was flaky, needed some care, but not in bad shape. I went to take the left sock off and it was stuck to the bottom of his foot. Found it. Here's my problem. So I go get a big basin of what we call normal saline. It's just salt water, warm it up, put his foot down in it, sock and all. And I go take care of some other patients. I come back 10 to 15 minutes later and I went to take the sock off. And as I did, I had to give a little bit of a kind of a pull to get it to separate from his foot so I can see what I'm working with here. Now, remember, he didn't have the big light on. He didn't want the big light on. And the reason he didn't want the big light on is because he had diabetic retinopathy, which means that the bright lights really hurt his eyes. So the room was kind of dark. So I get that right foot or right sock off the left sock off the left foot. Right foot was fine. Left sock off the left foot. And as I did, something went flying past my head. So now I'm counting toes. They're all there. All toenails are there. So what went flying past my head? I look up next to the floor, and it was one of those speckled, commercial floors. And up against the baseboard was this. This is a white painted flat metal thumbtack. This isn't the thumbtack. This is a replica of the thumbtack. But it had been stuck in the bottom of his foot. So now I'm looking at his foot, and he's got an area about this big around, hard, black, dead tissue. Now, we're good in medicine. We can heal a lot of things, but dead is dead. We can't bring stuff back from the dead. So I know this guy is in a really, really bad situation. He has got a dead area on his foot. Now, it begs the question, wait a minute, hold up. How can this guy have a thumbtack in the bottom of his foot so long that the tissue around it is dead and he didn't know it was there? I mean, if I step on a thumbtack, I'm sure going to know it's there. I'm going to be hopping around like crazy. How did he have a thumbtack and not know it was there? Well, because he had diabetes. And the wire that connected his foot to his brain wasn't allowing the signal to go through. His foot knew there was a problem. His brain did not. So I documented it all. I called the doctor, called the family, called the wound care specialist, did my wound care, did everything I needed to do, took pictures, all of that, and then I left. Not my facility, not my patient. But many, many months later, probably about 9-10 months later, I don't know exactly how long it was, I get assigned back to that facility. This time I'm on the long-term care side. So people that this is where they're going to live. This is the end of the road for them. I'm looking at my list of patients and I see Henry's name. And remember, he was on the rehab side. He was supposed to be going home. Now he's on long-term care. This is where he's going to live. And remember, he was in his 50s. So I walked in his room and I said, hey, Henry, I'm Patty. I'm the one that found the wound on your foot. How are you? And he pulled the sheet back and he had to have a below-the-knee amputation. He lost his leg over this. That's how serious it is. He lost his leg. Now, the real problem for me, actually there's two, is number one, why wasn't this found sooner? If somebody had found this sooner, we might have been able to treat it sooner, and he might have been able to keep his leg, and that wouldn't have been a horrible tragedy. Why wasn't it found sooner? Well, that tells me that the nurses weren't doing their head-to-toe assessments like they should have, and the CNAs weren't looking at the skin like they're supposed to and reporting any problems. So this was a failure on many levels. But there was another problem here too, because this whole situation was 100% preventable. We knew that he was diabetic. We knew that he didn't like bright lights. And we knew that if he was out of bed walking, there was a risk. If somebody had put shoes on him when he was out of bed walking, where would that thumbtack be?
Be in the shoe.
It'd be in the shoe. If he had shoes on, the thumbtack would be in the shoe, not his foot. This was preventable. This was preventable. He lost his leg because of something that was preventable. So now I want to ask you guys again, those of you who have ever been in the hospital and you walked around a medical facility in those slipper socks, is there a possibility there might have been a stray needle laying on the floor somewhere that got missed? Is there a possibility there may have been a thumbtack that had been on a bulletin board that accidentally is now on the floor? And you may not have seen it because those floors are highly polished and speckled. Does that make sense? What we think is a him problem could have very quickly become a you problem. Do you think you should have been walking on those floors without shoes? And neither should our patients. Does that make sense? Slipper socks are not enough. But let me give you an even worse scenario than that. That one was pretty bad, right? Okay. We're going to pretend that I have a bed right here. Okay, it's my bed. This is my roommate. I had a gallbladder surgery this morning. They just went in with a little robot, took out my gallbladder. I was supposed to go home at the end of the day because they don't keep you overnight for that. You go home. You'll recover better at home anyway. But unfortunately, my blood pressure was too high at the end of the day. They couldn't let me go home. So now I'm here in this facility, in this hospital for observation. They gave me a hospital gown, little slipper socks, and I cuddled up in bed, flipped on that TV. And I'm just going to take a little mini vacay while I'm here. So I'm laying in this bed. Now, this is my roommate. I don't get to pick her. They give me whatever bed is available. So this is my roommate. She just had a hip replacement surgery. She can't get out of bed right now because she had a hip replacement surgery. And she is on antibiotics because she got an infection in her wound. Now, it's been 3 days since her surgery. So, physical therapy got her up and tried to walk her a little bit because ambulation is always good for healing. So they tried to walk her, but because she is on an antibiotic, it gave her diarrhea. And as they got her up and started to walk her, she had a little accident. And, you know, housekeeping came and cleaned it up, and they got her back in bed, got her all cleaned up and everything. Now, eventually, I'm going to have to get up and go to the bathroom. So I get up out of bed in those little slipper socks, and I walk to the bathroom. Do you know what I walked over? Do you know what I walked over? Yeah. Yeah, housekeeping came and cleaned it up, but I guarantee you that there are still some particles that they missed. Now, I walk all the way to the bathroom. I do what I got to do in the bathroom, and I walk all the way back to bed, and I get back into bed with those slipper socks on. What got into bed with me? All of those pathogens. Now, that sounds bad, doesn't it? We don't want somebody else's poop in our bed. That's just pretty gross on anybody's radar. But here's the real problem. I have got multiple little incisions on me. Incisions are warm, dark, moist, and open. And as I toss and turn in that bed, those pathogens that are on my socks are going to move up the sheets. And eventually, I am also going to get a surgical site infection. And nobody's going to know where it came from. Everybody's going to be scratching their head like, she was young and healthy. Why did she get an infection in her incision? Everybody wore gloves. Do you see how that's a problem? You guys remember me saying 1 out of every 25 people in a hospital contracts something that they did not come in with? You guys remember me saying that? This is one of the ways it happens. We got to do better. So if the patient's feet hit the floor, they need shoes on. A question always comes up, well, what if they don't have shoes? What if they don't have shoes? Well, look in their closets. They probably do. Very few people go to the ER without shoes. But let's say they don't. They don't have shoes. You looked in the closets, you looked in the drawers, no shoes. All you have to do is tell the nurse, hey, patient doesn't have shoes. Yeah, well, I'll use shoe covers. Absolutely. 100%. But I'll also call the facility that this patient came from. If they came from a nursing home, hey, send me Roger's shoes. Or I'll call the family, hey, does Charlie have shoes? Can you bring me some? If he's homeless, he needs shoes to leave with. So I'm going to call the social worker, hey, Peter needs shoes. And social workers can fix that problem. The whole point is we have a team, but the team doesn't work unless you guys make an observation and report it. Otherwise, all those people are just sitting around with nothing to do. Making more money than you make. Put them to work. Make your observations and report them. Good? You guys understand this? Slipper socks are not enough. So when we put a gait belt on to help lift a patient to a standing position, this is a gait belt. So with a gait belt, it does not matter whether the buckle faces this way or the buckle faces this way. Nobody cares. Doesn't matter. Doesn't matter. What matters is the tag goes on the inside like every other article of clothing. So when you put this around the patient's waist, just make sure the tag is toward the patient. And I'm going to show you on me. Remember, this goes on the patient. I'm just going to show you on me real quick. When you put this around the patient's waist, you want to make sure that it's flat and not twisted. Has to be flat around the patient's waist, not twisted. This end goes through the first guard by the alligator teeth. So free end goes through the first guard, and then the teeth tell you which way to pull. I'm going to pull that way because the teeth are all pointing that way. If I try to pull this way, it's not going to tighten. I want to check it with 4 fingers. I should only be able to fit 4 fingers between the belt and the patient. If it's too loose, if you can do this, it's too loose. When you go to lift the patient, it's going to go under their breasts, under their arms, or they'll slide right out of it. We need it snug enough that it's going to stay. 4 fingers. Now we're going to take this free end and put it through the second guard to lock it in place. Now this tail hanging down might be in your way. Just tuck it up in the belt. To remove a belt, you take it out of the second guard and you hold the tail. Hold the tail. Slide the buckle along the tail. So to put it on, we hold the buckle, slide the tail, pull the tail. To take it off, we hold the tail and slide the buckle. Got it? When you take this off, don't slide it against them. Listen close. You hear that? That can burn skin or cause skin tears. So we want to loop it or bring your hands around to grab it. Good? Questions? Okay. So our care plan tells us that we're going to use a gait belt to lift our patient to a standing position. So we're going to put that gait belt around, check it with 4 fingers, and make sure the patient's feet are flat on the floor before we stand them up. Now, I am short. If I sit in this chair with my hips all the way back, my feet do not go flat on the floor. They may look like they're flat, they're not. My heels are actually up. So if you're trying to stand me up from this position and my feet are not flat on the floor, I'm actually going to topple forward. So you would want to ask me, are your feet flat on the floor? And I'm going to say no, and I'm going to scoot forward a little bit. So now my feet are flat on the floor. And then you can help me stand up using the gait belt, and I'm going to be stable. So you want to make sure your patient's feet are flat on the floor before you stand them. You're going to count to 3 before you lift them, make them a partner. And then you want to ask if they're dizzy before we move. So give them a minute. Ask if they're dizzy. After you do that, you're going to walk them 5 steps. For the test, they're actually going to give you a destination, like walk to the desk and back or walk to the door and back. They're going to give you a destination. And the reason that they're doing that is they're going to put something in your way on purpose. So a rolling table like this, if I were the evaluator, I would have that table there, and I'm going to ask you to walk the patient to the door and back. Your job is to notice that there is something in your way before you stand that patient up. Get the something out of your way. You don't want to leave the patient to take care of the obstacle. So make sure you look for obstacles before you stand the patient. Once you get them back to the chair, and you're going to help them sit down, they have to feel that chair behind them before they sit. If I can't feel that chair behind me, I don't trust you. If I don't know there's a chair behind me, when you try to help me sit, I'm going to be like struggling because I'm afraid I'm going to fall. So when you back somebody up, let me know when you can feel that chair. I feel the chair. Okay, now we can sit, and I'll help them sit. Okay. Jake, we need to update the software after class. All right. Proper body mechanics. Used to be years ago, I'm going to need you to adjust the camera angle down for me, feet. It used to be years ago that we taught CNAs to stand right in front of somebody, toe to toe, knee to knee. So when we're lifting, right, our lower legs are blocking their lower legs. That is an awful body mechanics position to be in because of a physics principle. Every action has an equal and opposite reaction. So if I'm lifting 150 pounds toward me, that means that my body has to compensate 150 pounds of force on my lower back. That's no good. That'll blow out your back within a short amount of time. So we do not stand toe to toe and knee to knee. What you want to do is stand at an oblique angle. And you can see that here. Patient sitting in chair. One foot is parallel in front of their feet, blocking their feet from sliding out. The other, or perpendicular, I'm sorry. The other foot is parallel to the chair. So if I've got somebody sitting in this chair, one foot would be across to keep their feet from sliding out. The other foot parallel to the chair. Now I'm standing at the corner of a box. One foot along each side. I'm going to bend at the knees, not at the back. I'm going to bend at the knees. Hold the gait belt around the back or the sides if they're a little larger. And on the count of 3, we're going to stand. 1, 2, 3. And that keeps me much more stable, but I'm not counterbalancing their weight. Make sense? So this is a little different than what some of you have, if you're working in healthcare, what some of you have been taught to do. You want to stand at that oblique angle, and this is going to help keep your back from long-term back injuries. Good? Okay. So these are the rules involved in this particular skill. If the patient's feet hit the floor, we talk about their shoes. So for the test, I'm going to say, I see you have shoes on. Do they fit well? Or I see you have shoes on. Are they tied appropriately? You want to acknowledge the fact that they have shoes on. Slipper socks are not enough. Do not walk somebody in socks. Now, they used to make us put their shoes on for this skill. But remember those evaluators, they want to be at home drinking their margaritas, not watching you tie shoes. 4 fingers between the gait belt and the patient. Feet must be flat on the floor, and we're going to count to 3 before we lift. We'll ask them if they're dizzy or weak when we stand them up, and then we'll return them back to the chair. You want to make sure they can feel that chair before you sit, and then we're going to remove the gait belt without pulling it against their skin. Good. So we're going to remove any obstacles before we stand the patient to walk. Gait belts go over the patient clothing. This cracks me up because that is a checkpoint, which means somewhere along the way, people were putting gait belts under clothing. Why? I don't know. They go over the patient's clothing. You're going to hold the gait belt around the back or on the sides to lift. If you got somebody that's really large, you may have to only go on the sides, but ideally you want to go toward the back to give you the amount of leverage you need to stand them up. Your hand or their hands should be on your shoulders. Do you see how this lady's hands are down at her sides, but do you see how that shifts those shoulders backwards? Now we're pulling kind of at the middle. Yeah, this is not good body mechanics. Their hands should just lightly lay on your shoulders to keep them moving as a unit. It's less strain on you or them. When you're walking them, you should be slightly behind into one side of the patient. And what that does is it allows that patient to be 100% in your vision. You should be paying attention to that patient. Patients don't just walk, I'm good. Ugh. They don't do that. Patients let you know that something is very wrong. They'll slow down. They'll get wobbly. They may get pale or sweaty. They'll put a hand out to the wall for stability or to their stomach or maybe even to their head if they're dizzy. They're giving you all kinds of nonverbal clues that something is going very wrong. If you're not watching your patient, you won't pick up on those. And then it just seems like we were walking and next thing I know, they're on the floor. Well, if that's the case, you weren't watching the patient. Make sense? Good. Watch your patient. And that's why we want to walk slightly behind them. We're going to let them lead. We want to monitor how they feel throughout the skill. How are you feeling? And then we're going to help them sit using that same body mechanics. Don't pull the gait belt across the body when you remove it. Make sure they're seated properly. And then you're going to do your closing to end the skill. So, do we know how to do follow me? Yeah, we got to.
Let me reset it. There we go. Okay. Step back in, please. All right. Follow. Go back in standard. Now it's in follow mode. Go ahead and test.
Well, just manually follow me. Yeah. Okay. So let me get a volunteer. Somebody come sit in the chair for me. Thank you. Awesome. That works. Okay, so I'm going to do this whole skill from beginning to end. I'm going to simulate hand washing. Good morning, Miss Jones. How are you? Fantastic. My name is Patty. I'm your CNA today. And do you feel like going for a little walk? Okay, I'm going to close your curtain. Let me go wash my hands and I'll be right back. I've washed my hands. We're going to get this out of the walking path. Okay, I see you have shoes on. Do they fit well? Okay, I'm going to place this gait belt around your waist. This is going to help me lift you to a standing position and provide a little stability while we're walking, okay? So I'm just going to slide this over. Lean forward for me. Thank you. And relax. We'll put it through the first guard by the alligator teeth. Pull it so it's snug, 4 fingers. Lock it in through the second guard. And then we'll just tuck this out of the way. Can you bring your feet out in front of you? And are they flat on the floor? Okay, you're going to put your hands on my shoulders in just a moment.
Okay.
And I'm going to reach around to the back of the gait belt. And on the count of 3, we're going to stand up, okay? So I'll put 1 foot in front, 1 foot beside. Go ahead and put your hands up here. And on the count of 3, we're going to stand. 1, 2, 3. You feel that stability? Feel okay? Are you dizzy at all?
No, ma'am.
Okay, when you're ready, at your pace, you can go ahead and walk to the door. Just at your pace. Okay, that's good. We'll go ahead and turn around. And then we'll go back to the chair. You feeling okay? Very good. When we get to the chair, back up. And when you feel the chair behind your legs, let me know.
Okay,
I'm going to help you sit. Put your hands on my shoulders.
Okay.
And we're going to sit. 1, 2, 3. We'll undo the
Now,
gait
would
belt.
this be considered a regular chair or
Mhm.
not like a wheelchair, right?
Right. You're going to do the same thing in a wheelchair too. Just make sure the brakes are locked.
Okay.
Go ahead and lift this arm up for me. Thank you. All right. Are you comfortable?
Yes. Ma'am.
Is there anything else I can get for you while I'm here? Would you like a magazine?
Nope.
Environment is clean. Open the curtain. Here's your call light. If you need anything at all, just feel free to call. This is going to be returned to storage. I'm going to wash my hands. Think about my skill. Make any corrections. My skill is done. Thank you. That did not take 5 minutes. Stand halfway behind them and on the side of them. Yes, yes. So it's an oblique angle. 1 foot in front, 1 foot beside, but you're standing at the corner of that box. Any other questions? Good. Good. Did you feel the stability, both sitting and standing? Okay, when you're practicing in here, please make sure you're practicing in the stationary chair, not the rolling chair, because it will roll on you. So make sure you're practicing with the stationary chair. All right, last skill we're going to learn. This is page 126. Partial bed bath. This is the biggest skill we do. So we go from one of the smallest to the biggest. Almost every principle is involved in this skill. So this is going to put everything together that we've learned so far. Short version, skill specific down here. Somebody with your level of experience should be able to do this skill in 19 minutes or less. And it will be done on a mannequin for the state exam. This is partial bed bath. That mannequin will be in a bed. But the cool thing about this is you already know how to do it. You just don't know you know how to do it. Okay, you already know how to do this skill. I am going to teach you one new thing, just one, but you're going to put together everything that we've learned so far to make the new skill. All right. So page 127 at the top of the page, it tells us to give the resident a partial bed bath and back rub. Wash the resident's face, neck, chest, abdomen, one arm and hand, and back with soap and water. Provide a brief back rub with lotion. Dress the resident in a clean hospital gown after bathing. Patient is lying on back in center of bed and can roll as directed, but is too weak to assist with bathing. So all we're doing is bathing the patient face to waist, front and back. That's it. You guys remember our washing rules? We check the water. It should feel warm. They check the water. Do you put soap in the basin? No, because you need water for rinsing. Whatever we wash, we rinse. Whatever we rinse, we dry. Don't get your bed wet. You already know all this. So there is one small principle that we have to learn, though. It's the last thing that we have to learn off of that back wall. And that's this we haven't gone over yet. We're going to use the leaves method for wet body openings. Jake, can you hand out washcloths, please? So to review, basins are no soap zones. We're going to use a paper towel to turn the water on. We're going to check it. It should feel warm. Your patient's going to check it. Change the water if it gets cold or soapy. Whatever you wash, you rinse. Whatever you rinse, you dry. And dry surfaces need to remain dry. Oops. We're going to warm lotion up first and wipe off the excess. We've learned all of those. Nothing new here. Nothing new here, but we do need to learn about leaves method. So if that washcloth that was just given out to you is just, those of you who are playing at home, you can go get a washcloth. It's just a plain square washcloth. If you fold it in half and then in half again, it makes a smaller square. We all have these kind of hanging out in a linen closet at home. But instead of looking at it like a square, I want to look at it like a diamond. And I want to hold this in my hand with the free points facing up. The free points facing up. I'm going to tuck in the side of my diamond between my pinky and ring finger and the other side between my thumb and index finger. And this is how I'm going to hold it for this skill. So we want the free ends facing up. So good, 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 good. So we're going to, these free edges facing up. There you go. We're going to turn that upside down. We want the free edges facing up. Good. Good. Okay, good. All right, so why do we want the free edges facing up? Why am I making a big deal out of that? That's right. So what we're going to do is wipe something with this area, wipe, and then we're going to fold that over, and that traps the contamination underneath. Now we have a new cleaning surface, and we can wipe something with that, fold it over, trapping the contamination underneath, have a new cleaning surface that we can wipe something with, fold that over, trap the contamination underneath. You've got a new cleaning surface. You can fold that over, and you can even use the backside as another surface. So we have 5 independent cleaning areas on this one washcloth, which is why we can use it for cleaning areas, even solid waste, and make it last longer than a wipe. Good. So when are we going to use this leaves method? Now, normally for hand and nail care, we just used a washcloth. We didn't care how we used it. But if we're going to wash any wet body opening, like eyes, nose, mouth, genitals, rectal area, wound, rash, sore, or incision, we need to minimize cross-contamination. So we would use this leaves method. Now, for partial bed bath, we're actually going to wash the face. And the face has doorways in it. You remember the doorways we learned about? The face has eyes, nose, and mouth. So we need this leaves method to clean for partial bed bath. So I'm going to take that washcloth, wring it out, no soap on the face, wring it out real well, and I'm going to wipe the eye, inner to outer corner. I'll fold that over. I'm going to wipe the other eye, inner to outer corner, and I'll fold that over. I'm going to wash the face, fold that over, and then I wash the nose last. Boogers. Fold that over. Good? Make sense? No soap on the face. Soap gets in the eyes, it stings. No soap on the face. So let's read this care plan one more time. It says, give the resident a bed bath and back rub, a partial bed bath and back rub. Wash the resident's face, neck, chest, abdomen, one arm and hand, and back. It also tells us soap and water. Now, I want to talk about that really quickly. For this skill, we're going to use soap and water because our care plan tells us to. In a hospital setting, you're going to use special wipes that are bacterial kind of preventative. It provides a kind of like a cocoon, a shell over the skin. So in a hospital setting, we have a special wipes that we're going to use for this. In a long-term care setting, we're going to use good old-fashioned soap and water. It also tells us to provide a brief back rub with lotion. This is not a massage therapy session. This is just small circles from bottom of the back to shoulders 3 times, just to wake up those blood vessels, stimulate blood flow, make the patient feel a little better. Dress the resident in a clean hospital gown. Well, that makes sense. Clean body gets a clean gown. And patients lying on back and center of bedding can roll as directed, but is too weak to assist with bathing. So, no soap on the face. We're going to use the leaves method on the eyes, nose, and mouth. We'll bring those washcloths out thoroughly. We'll support from below. We've learned that before too. Don't grab from above and move stuff. Support from below. Every time we use a washcloth, we're going to set it aside, except for the rinsing washcloth. So we were just talking about this morning. You can do this skill with 5 washcloths. So 1 for the face, set that aside, no soap on the face. 1 for the front of the body to soap. 1 for the front of the body to rinse. 1 for the back of the body to soap, and 1 for the back of the body to rinse. So you can do this with 5 washcloths. Good? But what if you don't have 5 washcloths? What if you're in a facility and somebody has used almost all the washcloths and all you have is 4? You can use 4. A rinsing washcloth, as long as it has not touched body openings, no doorways, rinsing washcloths can be reused. Not washcloth we applied soap to. Washing washcloths aren't reused. Rinsing washcloths can be reused. Good? So for the test, you can do this with 4. You can do it with 5. Nobody cares. But if you are the last person testing that day and all you have is 4 washcloths left, because they don't have an unlimited supply. They're like us. That is all I have. If you guys go through all of those, we're out of washcloths. So the evaluators will always make sure that there are 4 washcloths left for the last person. And if that's all you have to know how to do it with 4. If you want to use 5, go for it. If you've got 5. To dry, we use the towel. So for this skill, we actually need 2 towels. 1 to protect the bed and 1 to dry the patient. We'll turn the patient on their side. Should they be close to the edge? How do we keep them from being close to the edge? Yep, scoot them towards you and then roll them. So we'll wash the back, rinse the back, and dry the back. Then we'll give a little back rub with lotion, warming it up in our hands first, and wipe off the excess. Change them into a clean gown. I don't care when you do this. They don't care when you do this. Get them in a clean gown. I do it before I turn them over to clean their back. And the reason is energy conservation. Energy conservation. Remember, that's a big deal for them, isn't it? So if I wash the front, rinse the front, dry the front, turn them on their side, wash the back, rinse the back, dry the back, turn them back to their back, put the clean gown on, turn them back over and tie that gown, that's a whole lot of work for them. Or I could wash the front, rinse the front, dry the front, put a gown on. Yep. Turn them on their side, wash the back, rinse the back, dry the back, tie the gown. Which way do you think is better for the patient? Yeah, energy conservation. But for the test, they don't care. They don't care. I care, but they don't care. Good? So we're going to place all of our clean supplies on a barrier. We're going to get the water. We'll check it. We'll let them check it. We're going to protect the sheets with a towel. We're going to put a privacy blanket over. Once we're all ready, we'll put our gloves on. Remember, the first thing your gloves should touch is the patient. Wash the eyes, inner to outer corner using the leaves method, 1 leaf per eye. Wash the rest of the face, nose last. Whatever we rinse, we dry. So make sure you dry the face. Wash, rinse, and dry the front. Change the gown. Turn the patient over. Using scoot and roll, wash, rinse, and dry the back. Warm the lotion, give them a little back rub, tie the gown. Get them back on their back in the center of the bed and clean up. They are covered in a privacy blanket. We talked about this earlier. Leave them covered with a privacy blanket. Take care of all of your linens. Get your environment clean. Take your gloves off. Once your environment is clean and your supplies have been washed and stored, you can take your gloves off and then take the privacy blanket off and pull the sheet up. Do your closing. That's it. Good? Good. All right. So let me show you this video because it has good close-ups, especially of cleaning the face, which is important. Good morning, Miss Jones. My name is Patty. I'm your CNA today. How are you? Fantastic. I'd like to provide a partial bed bath. Is that okay? Wonderful. I'm going to close the curtain, wash my hands, get my supplies, and I'll be right back. Now that I've washed my hands, I can gather my supplies. I'm going to place the supplies on the overbed table. We'll start with a barrier, unfolding the barrier so the absorbent side is facing up, and this gives us a clean place to put our clean supplies. For this skill, we're going to need 2 towels, 4 washcloths, 1, 2, 3, and 4. I need a privacy blanket and a clean gown. Being careful not to hold the clothing against your uniform. I'll bring this over to the patient area. We'll bring this over here within reach, and then I'm going to get the supplies out of the drawer that I need. We're going to open the middle drawer and remove the basin, soap, and lotion. I'll put these on the overbed table. And I'm going to get a set of gloves. Okay, Miss Jones, I'm just going to get some water in the basin. I'll be right back. I'll use a paper towel to turn the faucet on. Check the water temperature with the inside of my wrist. It should feel warm, not hot, not cold. And we'll fill the basin about 1/4 of the way full. Okay, Miss Jones, I have the supplies here. Would you like to check the water temperature and make sure it's okay? It's good? Very good. Okay. So I'll put the washcloths in the water. And the first thing that we're going to do is place a privacy blanket over you. This is going to help keep you warm and provide privacy while we do this skill. We're going to spread this out without snapping it or shaking it. placing it over the sheet. And I'm going to pull your sheet down to just below your waist. Okay, now I'm going to put the towel on the bed. This is going to help keep your sheets dry, and we'll untie your gown. So I'm going to help you sit up by putting my hand on your upper back, and on the count of 3, we're going to sit. 1, 2, 3. Very good. I'm going to untie your gown. And then we'll spread that towel out underneath the areas that we're going to wash. Come on back. Very good. And I'm going to remove the gown on the side closest to me, supporting at the elbow as I lift. Okay, Ms. Jones, go ahead and bend your elbow. Thank you. And then we'll move the gown over to the other side, making sure that you're covered at all times. Now we're ready to start washing, so I'll go ahead and put my gloves on. We'll take the first washcloth, wring it out really well, and then I'm going to hold the washcloth in my hand so the free leaves are at my fingertips, and tuck in the 2 side corners. And this allows us to use a different leaf for each area that we're going to clean on the face. After wringing out the washcloth, no drippy wet washcloths, we're going to wash your face first. I'll start with your closest eye, and we're going to wash inner to outer corner using the leaves method, which is going to help prevent cross-contamination. So with the first leaf, we're going to wash the inner to outer corner of this eye. We'll fold that leaf over. And with the second leaf, we'll wash the inner to outer corner of that eye. Fold that leaf over. And with the third leaf, we'll wash the remaining skin of the face. We'll fold that leaf over. And with the last leaf, we'll wash the nose. And we're going to put this on the barrier. Whatever we rinse, we dry. So I'm going to take the towel and fold it around my hand so I have control over it. And I'm going to pat all of those areas dry using short, soft strokes or a patting motion. We'll set the towel aside. Okay, now we're going to take washcloth number 2 and wring it out really well so that it's not drippy wet. And then we'll apply soap to the top leaf. We're going to start cleaning the neck, behind the ears, under the chin, across the neck, the upper torso, down to the breast, keeping the patient covered at all times to protect modesty, down to the belly button, and up the side. Now, for the test, you will keep the patient covered. The evaluator will ask you to move the blanket if they would like to see. I'm going to go ahead and remove the blanket now so that you can see what I'm going to do. So we're going to move the blanket down, and I'm going to start again to show you how to clean the patient. So under the chin, behind the ears, across the neck, the upper chest, around the breasts. When you lift the breasts, we lift not with the palm, but with the back of our hand to lift the breasts to clean underneath, down to the belly button, up the side, down the front of the arm, all the way to the hand, supporting the elbow at all times, either with your hand or the bed, up the back of the arm, and we'll clean the armpit last. We're going to set that on the barrier. Whatever we wash, we rinse. So I'm going to get a rinsing washcloth, and we're going to rinse all of those areas the same way. So behind the ears, under the chin, across the neck, upper torso, around the breasts, down to the belly button, up the side, down the shoulder and the front of the arm, supporting the elbow, the hand, lifting the arm from below, washing the underside of the arm and the armpit last. We'll set that washcloth back in the basin for future use. We're going to take the towel, controlling the edges, and we're going to pat all of those areas dry or use short, soft strokes. Nothing vigorous. So the abdomen, down the arm, lift the arm up, support at the elbow, dry the hand, lift the arm to dry the underside of the arm and the armpit. We'll set this aside. Now, the care plan only asked us to clean one arm. So we don't have to go over and clean the other arm. And that's because that's what the care plan instructed. In some cases, you will have to clean both arms. In that case, you would just do that at this time. But for right now, we only had to clean one arm. We did that, so we're going to dress the resident in her gown. I'm going to spread the gown out, put my hand in through backwards on the armhole, lift her hand by holding her fingers together to place the sleeve over the arm, and then I'll lift at the elbow to bring the gown up. I'm going to make sure that gown is covering her. Put the privacy blanket back in place, and now I'll go to the other side of the bed to remove the old gown and put the new one on. Okay, now I'm going to move the blanket and remove the gown from this arm by sliding it off the arm, lifting the elbow from below with a flat palm, and then this will go in dirty linen. Now I can put the new gown on this arm by putting my hand in through the armhole backwards, grasping her hand, and sliding the gown over. We're going to lift from below at the elbow and make sure that the gown is properly in place. Now I'm going to go back to the other side of the bed. Okay, Miss Jones, I'm going to wash your back now. So I'm going to pull you toward me and turn you up on your side, and that way you're in the middle of the bed after the turn. Okay, go ahead and slide toward me. And then you're going to roll on your side. 1, 2, 3. Thank you very much. The evaluator will hold the mannequin in place during your cleaning, during the test. Live patients, of course, can lay on their side. So I'm going to ask the evaluator to please hold the mannequin in place for me. Thank you. We'll slide this towel down so it's covering the bed underneath the back. We're going to take our third washcloth, wring it out really well, and we'll apply soap to the top leaf. I'm going to wash the back from the neck down to the shoulders, all the way down to the waist. We'll set this washcloth aside and we'll get our rinsing washcloth. So we'll wring that out and we'll rinse the same way we washed. The back of the neck, the shoulders, all the way down to the waist. We'll set that aside and we'll take our towel to dry those areas. So I'm going to pat dry or use short, soft strokes and dry all of those areas. Now the care plan asks me to provide a brief back rub. So I'm going to take my lotion, put a little bit in my hands, and then I'm going to warm it up by rubbing my hands together. We're going to start at the base of the back and go up in small circles to the shoulders, and we'll do this 3 times. To the shoulders, come down, up to the shoulders and come down. And then we'll take the towel and wipe off the excess lotion. We'll remove that towel from the bed, putting it on the overbed table. And then we'll tie the gown. Come on back, Miss Jones, onto your back, and then scoot to the middle. Thank you. Okay, you're covered and safely in the middle of the bed. Let me go dispose of all of my supplies, and I'll be right back. So I'm going to put all of the supplies in dirty linen, being careful not to hold them against my uniform. And now I'm going to clean my basin, and we'll dispose of the water in the sink. Rinse the basin, and then dispose of the rinse water into the sink as well. I'm going to set that down, disinfect it per facility policy, and then pick it up with a paper towel. I'm going to get a clean paper towel to dry the inside. I'm going to get a clean paper towel to dry the outside. And then one more for the drawer. Okay, on the way, I'll place the lotion and the soap into the basin using a paper towel. And then I will use the paper towel to open the middle drawer and slide the basin with the soap and lotion into the drawer. We'll close the drawer with a paper towel and then throw them away. I'm going to remove the barrier, throw it away, and then I can remove my gloves. Okay, Ms. Jones, I'm going to move your privacy blanket now. So as I pull the blanket up, I'll restore the sheet. This preserves modesty and keeps the patient warm. We'll roll the privacy blanket up in a ball so that trailing edges don't contaminate other surfaces. Okay, I'm going to place this in dirty linen. We'll return the table to storage. Adjust the sheet for neatness and appearance. Okay, Ms. Jones, are you comfortable? Is there anything else I can get for you while I'm here? Okay, let me place the call light in your hand. So there you go. The call light is in your hand. If you need anything at all, please press that red button. We'll be happy to come help you. Bed is in the low position. The environment is clean. I'm going to open your curtain and go wash my hands. After washing my hands, I'll review the care plan to make sure that everything in the care plan was addressed with this skill. I'll think about my skill and make any corrections that need to be made. And once I'm happy, I'll tell the evaluator my skill is done.